This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 642, recorded on July 16th, 2020. I'm Vincent Draccaniello, and you're listening to the podcast all about viruses. Joining me today from New York State, Daniel Griffin.
Hello, everyone.
And also from New York State, Chuck Knirsch.
Hi, Daniel. Hi, Vincent.
Welcome back. It's been another week, and SARS-CoV-2 and COVID-19 is still in the news.
If you can imagine that, I don't know if you'll splice in that line about, viruses, the kind that make you sick, but I'm going to make sure I remind people that COVID-19 actually is one of those viruses that makes you sick. But let me start off with a couple quotations. There was one I prepared, but then I was listening to one of the other TWiVs, so I had to add a second. So the first is from Lin-Manuel Miranda from Hamilton. I hope everyone's had a chance to enjoy that on Disney Plus. If you don't have Disney Plus, go. Well, I don't know if you can safely go over someone else's house and watch it there. But in the eye of a hurricane, there is quiet for just a moment. And I kind of feel like, when I put that in earlier this week, that's the way I was feeling like things were in New York. But it's the storms clouds are starting to gather and move in. And, I've got a patient in the ICU right now on high flow oxygen who's not doing well. I've got another patient in a negative pressure room who probably could use the close observation of the ICU. I mean, the cases are starting to climb here in the New York area. So, the calm is not looking like it's going to last for us in the area. And the second was, and this is a quote from Dr. Ebazan in Mos Eisley, right? This is, the Star Wars in that den of iniquity. And he's speaking about COVID-19. I don't know if you remember this, where he says, he doesn't like you. I don't like you.
I remember that.
Right before someone gets an arm chopped off with a lightsaber. Right. But I want to remind people about how bad COVID-19 is. I feel like people have forgotten, right? I mean, we were talking just before we went on about people want to do a challenge study. A couple things just to remind people about, right? Here in the US alone, we have over 70,000, new cases per day. My birthday was yesterday. I'm older. You get older all of a sudden.
Happy birthday.
Happy birthday.
And on my birthday, over 1,000 people in the United States died of COVID-19, right? Yeah. I mean, that's, And I got an email actually the same day from a friend of mine in the UK. It's actually a physician that I've worked with in Uganda. He was basically saying, hey, this is really difficult, and sort of expressing concern for me, and then sharing a personal story. And he said that, quote here, a friend of mine, a work colleague, was recently woken up from 4 weeks of intubation only to be told that she had had both lower legs amputated and all her fingers. She's 52. She's Caucasian, no underlying health issues. So I know people have started talking about these challenge studies. We'll give them to younger people. Maybe this person wouldn't be young enough to be in a challenge study, but this is a scary virus, and the whole idea that you're going to expose people to this on purpose, you got to be willing to live with these kind of potential outcomes. So I really want to kind of remind people that this virus, it's bad.
But we also, Chuck and Daniel, remind me, if you only test the vaccine in 30, 40, 40-year-olds, you can't use it in 60, 70, 80-year-olds. Is that correct?
Yeah. The concern is with immunosenescence, and that's why either higher doses of, say, the flu vaccine or adjuvanted vaccines in the elderly are really important as you get older. Unfortunately, we start losing both our B and our T cell health when you start hitting about 30 years of age. It's a slow decline, but immunosenescence starts quite early. But really, it has an impact in, say, people over 60. So absolutely true, Vincent.
Yeah, I mean, that's, we'll end up with a vaccine for like 20 and 30-year-olds, but that's not really the target population. We want to be able to give it to people in their 50s, 60s, 70s, all the way on up.
The other thing with challenge studies, there's enough viral transmission in clinical disease that we can do proper studies right now with COVID.
Sure.
There is a role for challenge studies when you can safely abort the infection. And I put an exclamation point on that. And it's good, for instance, in predicting, the drift that you get with influenza. A challenge study would help you choose the correct strain so that instead of, when you think you have a vaccine that's 80% effective for influenza, and because of drift, you actually turn out to have a 20%. You could predict that earlier with a challenge study. So there is a role for it. I don't see the role right now with COVID, to be honest with you.
Yeah. I'm going to get back to this, but another quote. This is sort of a teaser. This will be wear a mask now or a wig later. And so I'm going to get back to why I say that. So as I started to mention, the case numbers are rising, and I think I said last time on TWiV, I think that it takes time for people to die, and the number of deaths per day is twice what it was when we recorded TWiP a week ago. It's about 500 a day. As mentioned yesterday on my birthday, it was over 1,000 in a single day. So the numbers are going up, and this is not great. The next thing, here I am appearing on this TWiV, but I'm going to tell everyone to stop, turn off this TWiV, and listen to TWiV 640. And it's a fantastic treatment of testing. And it was actually interesting. I've been working with the United Health Group on the whole concept that frequency is more important than sensitivity. We've got to start doing more testing, and we can't be handling all these result delays. And I think that episode does a great job. I was just in the phone mere moments ago speaking with the head of our urgent Pro Health New York Urgent Cares, Adam Fitterstein, and he was like, Dan, you don't know how embarrassing it was. I was just on the phone calling people back about their testing that was done on July 2nd.
Wow.
Right? That's embarrassing, right? I was like, Adam, I don't want to be the one making those phone calls. And I was saying it's really tough because, Pro Health, we were the leaders, right? Early on in March, like we were the only ones who sort of prepared and had capacity. Part of the way we did that was by partnering with the private labs, and the private labs just don't have the turnaround time anymore for various reasons. There are, sort of our Pro Health private patients where we've set up the ability to do it internally within a day, but that capacity is only so much. And calling someone, I'd hate if one of those phone calls was, 2 weeks later, by the way, 2 weeks ago, you were positive, right? It's really, the resulting delay is a disaster. But I'll say I won't go too much into the details of testing. Listen to 640. When that paper came out by Michael Mina's group, we were working on a similar paper, which we'd already submitted, but we don't do the preprints. Maybe I need to do preprints, get scooped if you don't. But no, he does a great job. If we don't start employing the technology, if we don't start using tests with rapid resulting without these resulting delays, we are missing the ability to intervene.
Our children might be able to go back to school if the daily saliva dipstick, and it seems like the technology's there. We just need to scale it up. I think this can be fixed, and I'm optimistic after listening to that. It was a great interview, Vincent, that you did. And I am optimistic that this can be brought online for this fall even. So let's keep our fingers crossed and maybe talk offline about how we can help them.
Yeah, no, and I listened to episode 640, and it's sort of reinforcing all the things I'm pushing for. I'm hoping the audience of TWiV is going to really push this forward. But yeah, the technology's there. The first rapid COVID-19 antigen test, it was a Quidel lateral flow assay, got FDA approval in May 8th. Here we are. We're in July. We're 2 months later.
Crazy. I've had already several emails from people who said they're writing their senators and congressmen and telling them to listen to that and get these rapid tests developed. So hopefully
we need them. So I know Anthony Fauci was on 641, and Vincent, I asked you to have him weigh in on school openings. So I'll talk about that. It's interesting, as a doctor, you think you take care of people and they call you because they have a disease. But a lot of the questions now is people are saying like, well, I would like to know if it's safe for us to get our kids back in school. Like what are the pros and cons? Can we do this safely? So some of the issues I think I've focused on is this is a place where kids get meals. A lot of kids get meals. And if anything, food security is food insecurity has become more of a problem in the United States in the last several months. Child abuse and neglect is a problem. There's, the alcohol stores were essential services, so we're seeing a lot more alcohol-related admissions. So we know that that's increased in the community. Kids lost a lot by missing school, but there's also like a regression. If you're not continuing to learn, non-traditional learners, which I have a couple of those. Even my traditional learner is struggling with staying motivated in this context. In social interactions, well, for most people, not for me, I kind of like this. Don't have to shake hands, but no, this is really tough for most people.
Me too. A mosh day is fine with me.
And also, it's interesting too for a lot of parents. School is the ability for someone to look after your kids while you go out and earn a living. And for some parents, it's going to shift even more to they really need to earn a living and, get food on the table and pay the rent. And so are they going to bring in the elderly grandparents to serve that role? I mean, there's really two sides to this. If you don't give those kids the opportunity to go to school and they're being taken care of by the grandparents, that may end up being the case anyway. So there's a lot of issues. And dealing with, how do the kids eat at school? How do you handle transportation? If it's a sleep away, how do you deal with the dorm rooms? My oldest daughter is looking at going back to William and Mary, maybe, but their idea is, one person in their room, no one else can go in that room. I worry about her mental health. Being, in that room. And she suffers from pretty severe migraines. So if she's in that room and no one can go in there and, maybe help her out, that puts a lot of strains on individuals. And it's very hard. Our schools were not designed for COVID-19. They were not designed with, the physical distance or even the space to create the physical distance. And a lot of the equipment, right? The putting up the plexiglass, shortages of plexiglass. The ventilation systems were not, again, designed for respiratory viral pandemic. So, this is going to be huge. But again, what would be one thing that would really be a game changer, Vincent? Testing.
Daily test. The kid before you go to school, the kid takes it. Mom, it's positive. Stay home for 2 weeks. It's perfect.
Yeah.
I mean, I didn't think it was possible. And a buck is really the point. When it's a buck, it's nothing. Everyone can do it, right?
Yeah. Yeah. No, I mean, it's the technology's there. And I think it's a paradigm shift. People have to stop saying, I need a test that's so sensitive that's going to pick up just a tiny. I care about people that have virus at a level where they're going to spread it to others. Totally. That's what we care about.
That's exactly Mina's point yesterday, that we don't care about people who have so little that they're not going to transmit. Right.
Yeah. So it's difficult.
By the way, we talked about the school issue with Dr. Fauci, and one of the things he mentioned is, we're concerned about the kids, but also the teachers. They're older, and we have to protect them as well.
Yeah, it's interesting because so much in our society has become divisive, and a lot of people, the teacher unions, the teacher unions are looking out for the teachers. Sure. And a third of all the teachers in the U.S. are over the age of 50. They're high risk, and they're looking at this and saying, hey, can you provide me the appropriate personal protective equipment or situation or, as a physician, right, would I go into the ICU without proper protection and expose myself and potentially, wake up missing some limbs and fingers? Is it okay to ask teachers to do that? I don't think so. I think, opening schools is a great idea, but you've got to do it safely for the children, safely for the parents, safely for the teachers.
Testing has to be part of it. And I see so many people are sending us plans on TWiV in their local schools, and so many of them do not have testing as part of it. It's just wrong. Now, of course, if you're in a part of the country where there are no cases, then maybe that will work, right?
Yeah, that's so we just got guidance on Monday from the governor, and it was reasonable guidance, I'll say, where he basically said if the 7-day moving average is below a certain threshold. He picked 5%. That might be a little high in my mind. And then another threshold, if it rises, you have to shut back down. So that's one way, sort of think about a pooled approach. You're saying, what's the prevalence in my community?
Yeah.
And as long as we stay below that, that helps us. And you got to do that. You got to constantly monitor what's going on in your community. If you're in Houston, like one of our friends, then maybe starting the schools up is not so great. If you're in Jacksonville, Miami, but yeah, there's certain parts of our country when it's different. And I think, you want a unified approach, but that unified approach needs to take into account regional situations and local situations and respond.
Daniel, the increase in cases we're seeing in New York, what does that due to? Is that travel, importations, or people getting wax?
I was entertained, Vince, and I was in the ICU, and they have the TVs on, right? And a couple things I want to, I always comment when I'm rounding is that, please don't, if I'm unconscious and intubated, don't put on cartoons, put on like PBS or something, or some British drama, make it appear that I'm intelligent and have, but it was one of the news channels was on, the individual was actually not responsive. They were ventilated. So I'm not sure they were watching it or who had it on. But it was the head of the CDC, right, Redfield, and he was explaining why we're seeing all these cases in the South. And I think, Chuck, you probably know it's because all the New Yorkers are going there on vacation and spreading it. And he said this; he wasn't completely straight faced. There was a little bit of a smile, but he wasn't joking, right? And come on, that's not what's going on. Part of it, as we're seeing in our area, is, we don't have closed borders, right? So if there's lots of it in the country, we started seeing people coming from other states. So that was part of it. I think I mentioned I had a woman from Pakistan who flew in with it. But another of the women I'm taking care of right now actually is a nursing assistant in the OR at one of our hospitals. So, maybe people are coming in for surgeries with it. So, we're seeing various different routes, all sort of little things. We saw a little bit coming out of the beach parties, right? And I don't know if it's actually so much the beach party as the after beach party when everyone gets together, in the air conditioned places. But
right.
yeah, it's as we mentioned, it's mostly younger people, so it's a different pattern of spread.
You're seeing the loosening up. In the park behind my house on Wednesdays they play kickball, the 20-somethings, and
sure.
Can't blame them. Everybody's going crazy. One of the 30 people out there was wearing a mask.
Yeah, I think, people have lost their fear of the virus. Our attention span can only last for so long. So I keep repeating to people, I know that you're done with the virus, but the virus is not done with us. So please take it seriously. Be careful. New data on treatments. Right? I came out with this PPI versus the H2 blocker. I don't know if everyone remember when everyone in the world bought Pepcid and it was going to save the world. And it was based on this observation that if you compared people who took the more expensive antacids, the protein pump inhibitors, seemed to have outcomes that were not as good as the people who took the cheap stuff. And it actually, this study basically showed that there was no protective effect to the H2 blockers, but there was a negative effect to the proton pump inhibitors. So, few more publications are coming out supporting tocilizumab that we've talked about. But, I quote my ICU colleague, Mina Macarius, is, "You do not have science until you have the results of a randomized controlled trial." So waiting for those UK folks with the recovery trial. Airborne transmission, right, has been in the press quite a bit. I'm not sure that anything has really changed there, right? I mean, I think that predominantly this is a droplet spread, but there are certain situations that I think we acknowledge where airborne transmission, this sort of small particles can occur. And the WHO, continues to recommend droplet and contact precautions, and airborne precautions when you're in a situation where aerosol generating procedures are performed. So sort of similar, this is sort of in the press. I'm not sure, but why, but it sells newspapers, I guess.
I asked Dr. Fauci, he said maybe a little bit, but still it's mostly droplet.
Yeah, I think that's what we've been saying for a really long time, and we'll just keep saying that.
I just don't understand why WHO had to come out and say, yeah, it's aerosol. We now admit it, but we always said that, and it's minor. It's a minor contribution.
Yeah, I mean, they sort of went. It's interesting when you go through the exact wording where they look at certain places and they say, so outside of medical facilities, I copied this down as I prepared. Some outbreak reports related to indoor crowded spaces have suggested the possibility of aerosol transmission. And they say, however, the detailed investigations of these clusters suggest that droplet and phomite transmission could also explain human-to-human transmission within these clusters. So, maybe in certain circumstances it's an exception, but that's not the main thing. Is don't stand within 6 feet of someone who's talking, singing, breathing, coughing, sneezing, and you're getting sprayed in the face or the eyeballs. So.
Did you see the wonderful report, MMWR, where the two infected hairdressers treated 139 patients? They're not patients. They're not patients.
You can call them patients. People that had like long hair, the hippies.
They all wore face masks. No one got infected.
Yeah.
Isn't that great?
I mean, I hate to say it, but you know what? Masks may work.
Why do you hate to say it, though? No, don't hate to say it. Someone will take
I jokingly say that, and now there's this whole thing that we get hit with. People want mask exceptions, so the other day there's a surgeon and he was like, I would like a mask exception so that when I operate, I can just, because I feel like the hypoxemia drops my surgical performance. I'm like, I'm just joking. That was the analogy I used. I was like, so if you want a mask exception, then when you go and get surgery, are you okay with the surgeon having a mask exception? So I think it's gotten a little bit adequate. I mean, come on, masks we expect our surgeons and our doctors to wear when they are doing surgery, because we don't really want them to infect our insides. Well, I don't want people to infect my face, my eyeballs, my mouth. Let's all be good citizens here and try to make this work. The other, and I'm going to sort of put these two together because I'm trying to sort of understand, but this is the concept of people who are sick with COVID and it takes a really long time to get better, right? And so I've talked to this about a long time, and a lot of these people have started to refer to themselves as the long haulers. And Vincent, you've asked many times, like, well, what percent? I'm beginning to think, at least, and the studies seem to be saying that this is much more common than an exception. And there was a JAMA paper as persistent symptoms in patients after acute COVID-19. And so they looked at folks 2 months out, right? And they asked these people, so it's 2 months since you got sick with COVID-19. How many of you are 100% better? How many of you feel like it's all over? And it was only 12.6% that said they were all better. So I'm seeing a growing number of people in the clinic who had COVID-19, and now it's 2 months, it's 3 months later. And they still have fatigue, they still have trouble breathing, they still have joint pain, they still have chest pain. Some of these were like athletes, and they're like, Dan, I can't go up a flight of stairs without taking a break. This is not okay. And so I think people look at the case numbers and they look at the deaths, but those case numbers, a lot of people who get COVID-19, they may not die, but there's a lot of disability and suffering associated with this.
We also see long-term effects after influenza, serious influenza.
Yeah, no, you do actually. And, particularly really severe cases, you see long-term effects. So this is not out of the box. This is just, boy, what a large number of people have had this. And now we're seeing a significant number. As far as doctors that manage this, because I know a lot of the pro-health doctors, and actually you'll like this, Vincent, I was on a call with a group down in Kentucky. There are a lot of medical groups that actually listen to this. They listen to TWiV, and they have someone designated to take notes, and then they sort of use that.
Great.
So, thank you for sort of setting up this forum where we can share all this knowledge. And I get emails back from clinicians too, sharing experiences. So this has been a nice two-way street. So a couple of things that we've noticed about these patients is seems to be a biphasic pattern to this illness. And this may, even in my mind, explain some of these concerns people have about reinfection. I'm not sure. I'm hoping, right? I'm an optimist here that maybe it's part of the biphasic, where people, they get sick initially, they get better, and then they feel worse. And then eventually they seem to get better. At least that's what I'm seeing. So maybe that biphasic is really just part of a long, reaction to this virus, and that second peak when, sometimes they've been PCR negative and now PCR positive. Maybe that's just part of this biphasic long haul and not necessarily anything beyond that. I always ask people to, remember the names of the 4 common coronaviruses. And when they look at me blankly, I'm like, yeah, I'm not sure our immune system is as good at remembering those as you are, but hopefully we'll see what that means. But one of the most frightening things I was talking to several people about this week, and my wife is like, yeah, that's just not true, is the women describe where they were sick, better for about a month, and then they start to notice that their hair is thinning. And, I do a lot of these visits through telehealth, through telemedicine. And the woman leaned forward. I was like, so what's up with your hair? And, it's not that the hair is falling out, right? The hair, we always lose a certain amount of hair each day, but it's that the hair is not growing back in. So we're starting to see something called telogen effluvium, which is it's something that we've seen in other situations when someone's been quite ill. The stress of being quite ill can actually put your hair follicles into a state of arrest that can last for a few months. So it's quite disturbing for these women, and I think that's what it is. I don't think there's anything. I hope there's anything special about COVID, but a growing number of women are noticing this, where they were sick with COVID. A month later, they started to notice that their hair is getting thinning, and over a period of the next 2-3 months, the hair not growing in and the hair loss we experience, they're starting to get bald. So that was my wear your mask now or wear your wig later, ladies. Men, I don't know, most of my hair is already gone. I haven't seen this in men, so there might be a slightly different dynamic in the hair growth. And now I'm just going to finish with last little things, and I'm going to go race sailboats while you guys chat more. But the new dogma, right? Early on, we were given a whole bunch of dogma, and I'm going to replace that with what I call the new dogma. And these are optimistic things. One is it looks like you can bend the curve of a respiratory pandemic. 2 is travel restrictions may actually help in certain situations. Face masks do work. Intubate only if you need to. We don't want to rush into that. We now are saying consider steroids in certain COVID patients. Look at anticoagulation. We know now that's a big thing. Don't give everyone hydroxychloroquine. And most importantly, listen to Anthony Fauci and the other scientists and physicians.
Exclamation point on that one.
Yes. Thank you to everyone, right, who's continuing to help us support FIMRIC's site in Viduta, Uganda. We are actually very close to reaching our goal. We're only about $2,000 a day away. So, head to parasiteswithoutborders.com and donate. And thank you for all the support, because as tough a time as we're having here in the States, talking to my friends in sub-Saharan Africa, things there are really tough.
You have time for a couple of questions?
Oh, I certainly do.
Okay. I don't want to hold you from your boat.
That's okay.
We have a letter from Dominic, who is a hospital internist, who wants to know about testing. I think a couple of months ago you mentioned work suggesting the oropharyngeal or saliva samples could be just as sensitive and specific. What do you think of studies to date? Should we change our practice? The work I have seen does not include huge numbers, but the results seem encouraging.
Yeah, I think, again, we're in a pandemic. We can't just continue with business as usual. And so, all these different assays out there, the quote unquote gold standards that we compare things against, were all given approval as nasopharyngeal swabs. And we've already started to gravitate, in young children. I tell, our urgent care, don't shove that all the way back to the middle turbinate. The child will never come back for another test, and you basically lose the ability to ever check that child. You have to be reasonable here. And back quite a while ago, United Health Group, the organization that I'm also the chief of ID for, did a study out in Seattle, and looking at over 500 people. And yeah, you're picking these people up by even just doing anterior nares. The stuff on oral, I think, is looking really good. Again, we do not need to pick up every single person who has just a very small amount of SARS-CoV-2 RNA. We need to pick up people that are contagious, that are transmitting, for the public health perspective. If we're clinicians and we're trying to understand a case and we're trying to decide whether or not to give steroids or tocilizumab or anticoagulation, okay, that's a setting where you need that more sensitive test. But the screening, the public health, we've got to sort of step back and say, let's start using tests where we have a lack of resulting delays, where we get that information quickly. Let's use tests that actually, a beautiful test is not a Q-tip shoved into your brain. A beautiful test is you spit in a tube and they tell you if you have COVID.
Dominic says he loves your concise, erudite review of evidence-based medicine some weeks ago. Should be required listening for all medical students and politicians. Quality medical care has been advanced greatly by rigorous science. Sadly, the federal government's premature imposition of comprehensive electronic data management systems has set us back years in other ways, such as through interference with the doctor-patient relationship, decreased consideration of differential diagnosis of clinical symptoms and findings, production of a great deal of garbage in health records, and physician burnout.
Thank you.
Would you agree with all that?
Well, the compliment, yes. No, a lot of it is a challenge. Yeah, this broad differential diagnosis. We do this as part of the academics. You're like, okay, that's great. Now, what do you actually think it is? And these 5-page H&Ps. It's like, yeah, that's great, but can you cut? What do you actually think it is? What should we be testing for? There's a tremendous amount of noise that has been introduced, and I try actually to give sort of these reviews up front, because I think we're currently in the middle of an info pandemic, right? Mm-hmm. Where, there's so much, and I'll call it a misinfo pandemic, where there's so much just stuff out there that may or may not be true. So I try to do my part, and Vincent, Chuck, and the rest of the TWiV team, you guys do a great job. I mean, I listen to all the TWiV episodes myself, sort of helps me cut through just all the noise that's going on. And unfortunately, the patient record has become so full of noise. It's a challenge for us.
So Diane is a retired RN and mother of a virologist who has a question for Daniel. I have a good friend who's an RN on an OB unit in a small rural hospital. She was recently exposed to SARS-CoV-2 at work because a traveling nurse who also works on the unit flew home to Houston to visit her boyfriend. When the traveling nurse returned to work, she was asymptomatic but voluntarily tested, went to work, and then a day later received her positive test result. So she spent the day, although with a mask on, in close quarters with a few other nurses, staff, and a handful of OB patients and newborns. On top of all this, my RN friend received a phone call from a contact tracer who said that she, my friend, was not required to have a test for COVID before returning to work since she had been wearing a mask on the day she was exposed. I'd love to hear your thoughts on how this could have been handled differently. To me, the traveling nurse should have been required to quarantine and test before returning to work, having visited a known hot zone. I understand it's not easy with limited staff. It seems more prudent than allowing her to potentially infect and sicken patients and coworkers. With testing readily available in our community, shouldn't contacts of a positive case be required to test? Thanks for all you do.
All right. So Diane from Steamboat Springs, this is, I listened to this and it's frustrating to hear. I mean, so there's all the sort of problems in what you write about. One is the resulting delay, right? If this person had been tested and we knew right away that they had a level of virus that was potentially going to be spread to others, then all this could have been avoided. So testing is so key. It's great to then have a more sensitive test that you hear about a day later after you've already sort of cleared the first hurdle. The other, which is interesting, is, here's someone who's traveled from a high risk state. The problem is the whole incubation period. You leave that high risk state, you may be PCR negative now. You may not be shedding virus now, but anytime in the next 14 days, you may start to get sick. You may start to shed virus. So coming from one of these places, either really you have to quarantine for that period of time and then get a negative test, or testing has to be something that lets us know if you're safe. And particularly, you listen to this. She's working with, children, with newborns, with OB patients. A lot of these are pregnant. We now have some signals suggesting that there might be concern in that population. This is difficult. Now, the other, which is, again, we're still in this paradigm of limited access to testing where you're exposed to someone and they run through basically a scenario where they say, were you within 15 feet of this person for, within 6 feet of this person for more than 15 minutes without a mask and glasses? They sort of, they're setting a bar for testing. Which reminds me back of how frustrated I was back in February, right? The bar then was you have to have come from Wuhan, you have to have a fever, you have to have trouble breathing, no test for you. And then even, right? I mean, even when we identified that guy in Westchester, we're like, this guy was not in Wuhan.
Yeah.
They're like, yeah, well, he must have gotten it from someone in the temple. I'm like, so here we still have barriers to testing. People got to get tested.
Bob in Philadelphia once says lots of buzz, but very little science regarding giving inhaled steroids early in the course of COVID. Any thoughts?
Yeah, so Bob, we don't know. I mean, early on, and I still say I'll approach it this way now, I try to think about what's going on and what I'm trying to do. So the first 7 days is viral replication, right? And I don't see a role for steroids in the viral replication phase. The second week, that's when we start getting our inflammatory, our cytokine storm. People start to get hypoxic. That's when it made sense to me to start targeting the immune response. So we don't know about inhaled versus systemic steroids. So I'll sort of leave it there. Like I would say the thinking and understanding the pathophysiology would still say avoid steroids during that first week. Data now on systemic steroids during that second week. But this is something that would be great to study because so much of that inflammation we think is coming from a pulmonary source. So this, in my mind, would make a lot of sense to look at.
And one last one from a septuagenarian mouse immunologist at the University of Massachusetts Medical School in Worcester. Is it possible that older individuals are more sensitive to infection because more of us have had our tonsils removed?
That's one of those questions that they could, one of these large medical centers, maybe one of our listeners could very sort of quickly do a medical search, right? And just look at, okay, all the people who had tonsils out, who didn't. So this is a project for one of those sidelined medical students or a resident or a fellow. Talk to your medical informatics team and say, hey, can I look at people who had tonsils removed, people who didn't, and look at COVID-19 outcomes? So, yeah.
So we don't know is the answer.
Yeah, we don't know. But it's a question you can ask.
But we think the disease in older people is an immune response based disease. So
yeah, I don't think the tonsils are going to play a role. In all honesty,
because you're just two, and you have more other lymph nodes throughout your body, right?
Yes, it's like Carl Sagan, right?
Yes,
there's like dozens. No, there's lymph nodes galore. So yeah, you take out two. If you remove 2 stars from the sky, unless they were special ones, most of us wouldn't notice. These are special ones.
There are billions and billions of lymphocytes for sure, right?
Yes, there are actually.
Okay. Daniel, thank you again for joining us. Enjoy your sale.
Oh, my pleasure. Everyone take care and be safe. Thank you for listening.
And Chuck, thank you as well. Joining me today from Fort Lee, New Jersey, Dixon Fisherman Despommier. Hello, Dixon.
Hello there, Vincent. Fishing has been sparse because of the high water temperatures, but the observation of nature has been wonderful. The other day I was fishing and I saw an osprey chase down an eagle trespassing.
Also joining us from Austin, Texas, Rich Condit.
Hi, everybody. How you doing? We got 94 degrees, headed for 97. It's a cold snap.
Yeah, right.
And it's sunny, so we're doing okay. Oh, and by the way, the hospital and 7-day rolling average of hospital admissions in Austin has been level for a week. It's still uncomfortably high, so that the actual hospital capacity is not quite level. It seems to be creeping up a little bit, but so far so good. We can handle it.
Also joining us from Madison, New Jersey, Brianne Barker.
Hi, it's great to be here. It's a little cooler here. It's 80 and pretty gray.
That's what it is here. It's really gray outside, except I don't do Fahrenheit. So, and finally, from Western Massachusetts, Alan Dove.
Good to be here, and we up here in the Arctic North. It's 70 Fahrenheit, 21 C.
70.
Yeah.
Oh,
yeah.
Bring some of that down here.
And it is overcast. It was raining a little bit this morning.
26 C here in New York. It's cloudy as anything. It's fine. And we, of course, reach another high of coronavirus cases in the U.S.
Oh, yeah.
We're doing a great job. We're testing like crazy.
We are. The more you test, the more you find.
Right. Yeah, if we'd stop all this testing, the pandemic would be over, right? That's
exactly
amazing.
Right.
So this week we had two interesting TWiVs that you need to listen to. 640 with Michael Mina, which completely changed my view of testing and how to get through this pandemic. Rapid, cheap tests you could take every day for $1. And the whole idea that we don't care about people who are not transmissible is brilliant. Right? If they're not shedding enough virus to transmit, we don't care if we miss them, if the test is not accurate enough. Listen to that. And of course, 641 with Tony Fauci. We're really honored to be able to talk to him. And I hear that after he talked to us, he talked to Mark Zuckerberg. Don't bother with the Zuckerberg crap, okay? If you want to just listen to Fauci, that's fine, but there's nothing there about science. Who cares? Zuckerberg doesn't know an ounce of science. All he knows is how to screw up the world and keep doing it so he pours money into shareholders' pockets. So our TWiV with Rich Condon, good science, all science questions. And today, of course, you've already heard Daniel Griffin talk about what's going on. Cases are going up again in the New York City area. So we have ways to go. However, if you like what we do, what is it that we do? Well, we just talk about science in a calm and unassuming manner.
There's no grumpiness at all.
There's no grouchiness.
I was about to talk about rack and yelling.
Yeah, isn't that cool? Rack and yelling, a new term. I like that very much. Rack and yelling. We'd love your support, financial support, microbe.tv/contribute. So we're going to start out with a little announcement from Rich Condon. What did you do last night after talking with Tony?
So because of TWiV, yesterday was a great day. Because of TWiV, I have been in touch with the president of the Travis County Medical Society, John Abikalan, who, along with the dean of the medical school, Dell Medical School, Clay Johnson, has been, and also assisted by the vice dean for professional practice, Amy Young, has been hosting for the past several weeks a virtual town hall meeting. And we can put a link in the show notes to that because I think everybody would be interested. They do a variety of topics. They meet for an hour and they take up little presentations and questions and answers. And so last night I was able to join them kind of on the spur of the moment in a way because coincidentally they had Jason McClellan on, okay, talking about the structure of the SARS-CoV-2 spike protein. And he gave a wonderful presentation that I think all of our listeners would really appreciate. And we had some good questions and answers after the end. You guys, did we do that spike protein structure paper?
I believe so, yeah.
Yeah, I almost feel like we ought to do it again or have Jason back or something like that. Do you know that they went from sequence to a submitted manuscript in a month?
Yeah, it's really great.
It's unbelievable.
We could have him come on and talk about it. Yeah.
And he has a really nice perspective because that's this, it's his prefusion protein that they're using in the Moderna vaccine and in the Novavax vaccine. And so, and I think.
What do you mean his? What do you mean his?
Well, his laboratory engineered the modifications to create the stabilized
but
prefusion
Moderna started this in January, right?
The genetics that resulted in the structural biology that resulted in that prefusion structure was research from his lab that was done with, he solved the structure. If I got this straight, we ought to have him on. He did the structure of the MERS spike protein and the SARS spike protein and figured out how to engineer these couple of prolines into the structure to freeze it into the prefusion. That's why they were able to do this in a month. Right. They knew exactly the changes to make, and they had, a model already for what to expect.
The reason I'm asking is because I know Barney Graham at the NIH has also done that for paramyxovirus fusion proteins like respiratory syncytial virus, right?
Okay, and so if I've got Jason's history right, he was a postdoc with Barney Graham.
All right, there you go.
There you go.
Maybe he did it there.
Okay, so I think it's possible even that those structures were done there. We'll have to ask Jason. Okay.
So for those of you who don't know, we're talking about prefusion, and I'll bet there's a bunch of you who don't. So the spike protein on the virus has to attach to the cell receptor, and then it catalyzes fusion of the virus in cell membranes. To do that, the spike undergoes a massive conformational change that would be a post-fusion structure. But you don't want to make antibodies against that. You want to make against the structure before it fuses, because that's what's floating around in your fluids.
This and then this. And you don't want antibodies against this. You want antibodies against this, because that's the original part of the virus that attaches to the protein.
That's what we mean. Very clever. 2 amino acids will lock it in the prefusion conformation.
We could get all of this locked down, as it were, all the history and everything else from Jason, because Barney Graham's involved in the Moderna vaccine.
Yeah.
Jason's involved in that as well, at least from this point of. From the point of view of providing the structure. So it was a wonderful conversation. I recommend that. And actually, I would go further and recommend in order to warm up for this, okay, I looked at what they had done previously, and the direct previous episode, what they had on the mayor of Austin, Steve Adler, who is quite a guy. And he is, I think, a marvelous example of how a politician should function in this circumstance.
Does that mean you should listen? He said, listen.
Yeah. He was awesome. He was just awesome, and I'm really proud to have him as mayor. That was a really interesting interview. Cool. I mean, All right. I will say no more.
We'll put a link to that. You can watch the videos in the show notes there. All right, we have 2 papers I wanted to discuss with you before we move into some email. This is important. This will teach you some basic virology. Let me just preface this by saying, as you all know now, a virus can change the world. You're seeing it happen, right? So it makes sense that you understand how viruses work. That's what we've been trying to do on TWiV for 12 freaking years. And mostly no one's listening, a few thousand people. And now you realize what you've been missing. You need to know this. And, I get letters every day from people who say, I joined you. I probably won't stay after the pandemic. And you know what? You're making a big mistake.
There'll be another test.
There'll be another test.
There will.
This may be on it.
We can make a vaccine. We can make a vaccine in 6 months, whatever. There's going to be another one, because this vaccine won't work for the other one. And you know what? You can go binge on Netflix if you want. You're not going to learn squat by doing that.
Think how much nicer it would be that when we have the next pandemic, if you were the one who knew lots of things and could tell your friends.
Yeah. Now, you don't have to listen to 2 hours every week. I understand that's a horrible burden. Oh, but we do 2 hours. Oh, no, sorry. I understand you can't, but you should pop in now and then after the pandemic and keep learning. Really, that's what I want to do. I want people to keep learning because, entertainment's fine. I get my entertainment through these guys and chatting about science. That's really cool.
Well, I get entertainment on Netflix and other things too. But this is definitely part of it. Is this,
Alan? We had a great letter on Wednesday from a Southern California hairdresser. who was basically saying, all these actors and actresses, or actors, I should call them all, whose hair she cuts, don't know squat about science. They're superstitious. They look to the Mars rising or whatever it is to plan their days. And these are the people that most of you idolize, the actors. And that's why Robert De Niro wanted to have the Wakefield anti-vax movie at the Soho Film Festival a couple of years ago, because he doesn't know anything. In fact, the letter writer said these people would not be able to understand a word of what you are saying. Now, I'm not saying that all actors are like that, but please do not idolize those people. Idolize Tony Fauci. Idolize the people who are making the vaccine.
Well, I think
idolize the physicians who
you should
are taking care
appreciate
of
people for what they are good at and what they do. I mean, great acting is a wonderful thing to see, and I respect a great actor for being a great actor, but I don't expect a great actor to give me good advice on how to respond to a pandemic.
Well, the problem is, Alan, that people idolize actors.
Yes, we've built a system that puts people on a pedestal and assumes that they are experts in all things if they're good at one thing.
People will think nothing of watching football all weekend and not spend an hour listening to a science or watching a science video. That's all I'm saying. I'm on a soapbox. Is that what it says?
Yes. You were definitely on a soapbox.
You're on the soapbox, and I am wishing that I could have that person cut my hair, because I would love to have a conversation about viruses with her while she cut my hair. Okay. That would be entertainment for me.
Actually, yeah, she was in Southern California, right? Was she in L.A.?
She said Southern California. She didn't specify.
Because I'm in the area now and then. It'd be nice to have her know what her
You're in the area? What are you talking about? You're nowhere.
Not now.
We're talking about a year. Eventually. You're not going anywhere for a year, Dr. Condit.
My hair's going to be really long by then.
Hey, did you notice mine is cut?
Good work.
You've become a little more hirsute around your chin.
My hair is cut. I couldn't take it anymore.
All right.
But I did not go to a salon.
So, Vincent, you'd be proud of me. We were at a blueberry picking site yesterday before I came down here. And the guy that runs it is fairly erudite. He runs a barn where they have barn dances and things, and he likes traditional folk music. And he started to ask something about my background, and I started to talk to him. He says, "What's this week in virology? You just mentioned something." And I gave him the spiel, and I gave him the address, and he's going to listen. A blueberry picker.
Yeah. What's TWiV? Figure it out, folks. Google it on your phone.
Well, no, back when I used to go to the gym, I would wear that was one of the TWiV T-shirts to work out.
Sure.
So, got to get the advertising out there.
This is true.
Weren't we talking about having some TWiV masks made up at some point? Did that?
Yeah, they're done. I've designed them. They're on Zazzle. Is that the company? Zazzle?
Oh, well, I've got to get one.
Here.
Okay.
Absolutely.
Let me show you, actually. Since we're on Zoom, look at this.
We are on Zoom.
I can actually show everyone TWiV. I can search Zazzle for TWiV. Look at this. I'm going to share my screen. Oh, my gosh. Technology, baby.
If it works.
See? There's the TWiV mask on the left. And these are our TWiV World Tour T-shirts from 2018 and 2019. But this is the mask, right? I put a virus with This Week in Virology there. So there it is.
Yeah, send one to the president.
Awesome.
What president? The U.S.?
Donald J. Trump. He's got a mask now. It's got a presidential seal on it. Okay. I looked real close. It was the presidential seal. It wasn't a TWiV. It wasn't a TWiV logo.
Yeah, Richard, it's right next to the hole in the mask.
I just ordered a couple. But Zazzle.com, okay? 2 papers today. New England Journal. This is the preliminary study of the mRNA vaccine. It's called an mRNA vaccine against SARS-CoV-2 preliminary report. And as you will see, it's just day 57 out of many days, but they're reporting this. So this, of course, is there are a lot of authors on this paper, but largely out of Moderna, and many other people have participated in this trial, Kaiser Permanente, and others. But
the Vaccine Research Center at NIH.
Vaccine Research Center, and then this is all these authors, and there are 30 or so, are for the mRNA 1273 study group. And 1273, of course, the number of amino acids in the spike protein. So what do we got here? Phase 1, dose escalation. What does that mean? They give people different doses. It's kind of a cool name, right? Yeah. Instead of saying they give people different doses, we call it a dose escalation. Open label, so you know what you're getting. For safety, reactogenicity, and immunogenicity. 18 to 55 years of age, 2 injections, 28 days apart, of either 25, 100, or 250 micrograms, I believe, into the deltoid muscle. And this is, of course, the mRNA encoding
That's up here. That's the same place you get your flu shot.
Where's that, Alan? Show us. Right up there. Yeah, that's right. That's where you get the flu shot. This is the SARS encoding, the spike glycoprotein encoding mRNA, which of course is pre-fusion stabilized, as we mentioned, and it's encased in a nanoparticle of 4 different lipids. And these people were not screened for previous infection, all right, before they're enrolled in the trial. And this is a report of what happened by day 57. They're going to be following these people for at 119, 209, and 394 days. But of course, if we waited till the end to do the phase 2, that would be well into next year. So we can't really do that. Although that would probably be classically how you would do it.
Well, there's the normal workflow and there's the pandemic workflow. And the normal workflow would be that you would follow these people a little further out before you moved into phase 3. But we don't have time for that because people are dying. So
that's right. And I totally agree. Even though I'm grumpy, I agree with that. That's totally good with me. So let's go through the results. First of all, these people, 45 participants, they were enrolled between March and April. And they got, again, these 3 different doses, 2 inoculations. One person had some issues, so they bowed out.
Did you say a total of 45 people? 15 in each group?
Yeah, 15 in each group.
I did.
Each dose group.
All right. No serious adverse events. In other words, serious meaning, when you write a trial, you say, if this happens, we're going to stop the whole trial. It would be a trial halting rule, basically.
Somebody dies, somebody as a direct result of the vaccine or something really bad, some horrible systemic immune response to it, something like that would be a serious adverse reaction.
So that's good that they've got the 57 days and we didn't have to halt the trial. First dose, systemic adverse events reported by 5 people in the 25, 10 in the 100, and 8 in the 250. They're all mild to moderate. And, things like fever and aches and so forth.
The most common in all of these things is going to be a little bit of pain in the injection site.
Yeah.
Correct.
Right.
It's pretty much the profile of a flu shot is what I'm getting from this.
Yes.
And then after the second, more common, 7 of 13 in the 25, all 15 in 100, and all 14 in the 250.
And it's interesting. There's a higher incidence of adverse effects in the second shot, and I'm making this up. And Brianne can back me up on this. But I'm thinking that there's getting a little bit of a cytokine hit. Okay, because they're already immune and they're getting a boost. Does that make any sense?
Anamnestic response?
It might be some kind of anamnestic response. It might be a cytokine boost. Definitely.
Sorry, how many weeks after the first one?
It's 28 days.
28 days.
28 days.
So 4 weeks.
Yeah, that's time enough. Should be only IgG at that point, right?
It should have switched to IgG at that point, yes.
Yep.
One person in the 250 microgram group had very high fever, 39.6 Celsius. Severe fever.
That was about the worst.
That's about the worst thing. Okay. So looks safety profile is pretty good in this age group, right? And again, the age group is 18 to 55 years of age. Now, you might imagine that, and right now, that's who you could use it in if this were an efficacy trial, but you'd have to do this in older people. Like Dixon can't get this vaccine yet. Nobody can, of course. All right, so what did it do in terms of immune response? First, so they measure immune response in 2 ways, and the first is just measuring IgG that binds to the spike protein. all right, binding antibody. And they can measure that and quantify it. Those titers go up rapidly after the first vaccination, seroconversion in all participants by day 15, which is, a classic immune response, adaptive immune response. The nice thing is, and then they had dose-dependent responses in the first and second vaccinations. For both assays, the median magnitude of responses after the first in the 100 and 250 dose were similar to the median magnitude in convalescent serum specimens. Now, they only had 3, I believe. So I would say we can't really compare them yet because we need to have a greater number of convalescent serum.
No, don't they have 38?
Well, maybe I'm thinking of the neutralizing. The neutralizing,
I think that's the neutralizing. The table 2, it says numbers 38.
All right, that's okay.
Yeah.
Still, but I'd like to have a broader range. But okay, that's fine. And then they give some ranges. After the it's a boost. These ranges exceeded that in convalescent serum specimens, right? So that's good too. So, but this is just total IgG binding the protein. It doesn't say about neutralizing antibodies. So that's good. Looks good so far. Then they say neutralizing antibody. They're measuring this using a pseudotyped virus, not actual bona fide SARS-CoV-2. And, they make a case that maybe that's a good surrogate, but I think you need to compare it at some point before you can say that. Because
so they only do the live virus neutralization. That's the one they only have 3 comparisons with convalescent serum, and they do a lot less there. If it was a good comparator, then that would certainly be nice to move this out of the BSL-3 lab and make this a little easier to do for those neutralization assays for more people. But you're right, they need to do a little bit more comparison first.
I think there has been some work from other groups comparing that, though, hasn't there, with a pseudotype virus versus SARS-CoV-2, or am I misremembering?
Yeah, in the serum screenings that have been done, right? But not after a vaccine trial.
Right. But they're trying to reason by analogy so that they can go ahead and get this thing done. I agree that it would be nice to see them, under the conditions they're using in this assay, do the comparison and then verify that under those same conditions you get the same.
Yeah, you have to. And look, not having a BSL-3 is no excuse. I'm sorry. The U.S. is pouring billions into this. There are plenty of
Somebody
BSL-3.
has a BSL-3.
It's not that hard. Once you have the BSL-3 and are trained, it's not that hard to work in it. So there is no excuse not to do at least the studies to say, yeah, this is the same. And right now we don't know. They're making a case that it could be, and that's fine, but you have to have the data for that. So none of these people had neutralizing responses before vaccination, which is cool because remember, they didn't pre-screen people.
Right.
And then after the first vaccination, they got neutralizing responses in less than half of the participants. And after the second, they got neutralizing responses in all. And these are, of course, serum antibodies. And I want to ask Brianne something about that in a moment, but this is serum, right? And of course, these responses went from low to high, depending on whether you got 25 or 100 or 250 micrograms. And they say these responses were similar to values in the upper half of the distribution of values for convalescent serum specimens.
What was one of the big take-home messages from this for me was you need the boost.
Yes. You do need the boost.
The boost was really important.
This is not a one-shot vaccine.
No, this is unfortunate.
At any dose.
I think this is unfortunate because logistically, it's good. We got to immunize everybody. That's hard.
Yeah.
It's not just.
Yeah. So we're going to have to immunize everybody, and then a month later, immunize everybody again. I mean, it won't actually play out that way. It'll be whenever you get vaccinated, a month later, you'll go for your booster shot, and then if this ends up being a successful vaccine.
Yeah.
Yeah, that really stood out to me in the later data on the T cell responses.
Yeah,
you really needed that boost for the T cells.
Yeah, so they say the average responses were generally at or above the values of 3 convalescent serum specimens tested in this assay. Again, the pseudotyped virus assay.
So, Brianne, what happens with a boost?
So in the prime, in the first time you're getting the antigen, your B cells and T cells are changing into cells that are called memory cells. So they're differentiating and getting better at responding, and having a lower threshold needed. So they don't need as much antigen, they don't need as much stimulation to get turned on. So those cells are becoming memory cells in the first situation. And with the second boost, now you're triggering those memory cells, which should be able to divide faster and divide more and make more antibodies. And in fact, you can then have them prepared for a tertiary response. So if they were to see the virus again, they would make even a better response.
So how long, I remember, what was that? Concerto in B.
Yeah.
A long time
Oh,
ago.
yes.
It's a great one. Yeah.
The antigen sticks around for quite a while, doesn't it? I mean, kind of closeted away in the lymph node, and the B cells are playing with this thing, but maybe does the boost then give them a new supply of antigen?
Exactly. So there usually will be a little bit of antigen sticking around in the lymph nodes. There are a special type of cell called the follicular dendritic cell, or in my immunology class, I say it's a cell that's kind of like flypaper and just gets stuff stuck all over it. That comes by. And so there will be some antigen left there for the B cells to respond to. But you're going to be able to get a much better response. Some T cells coming in to do B cell help, all of those types of things when you see the antigen the second time.
So after the first time the antigen is being presented there and some cells are picking up on this and you're getting your education of your B cells, and then it kind of gets buried under the papers on the desk in the lymph node.
Yeah, exactly.
It's not getting a lot of attention. And then the boost comes in and, oh, yeah, that was for real. Here's a second notice. And
you guys were serious.
Yeah, this is serious.
The boost is graduate school.
The boost.
So, Brianne, these antibody responses were measured in serum. But of course, infection doesn't begin in the serum. It begins in the respiratory mucosa. So what does this tell us about antibodies that will end up there?
So they don't look at different types of antibodies here. They just look at antibodies in general. So we are making the assumption that this is going to give us more antibodies in the respiratory tract. Mm-hmm. But you're right. They don't specifically measure that. Given that they gave the vaccine in the muscle, which is sort of systemic, they are assuming that they're getting immune responses throughout the whole body. And so we think that there would be some decent responses in the lung, but we're not getting any preferential responses.
Now, when they do the efficacy experiments in the phase 3, maybe phase 2 also, would they measure mucosal antibody, or they're just going to look at infection?
I think that with efficacy, you largely just look at infection, but I would certainly love to see their protocol and see them doing that measurement.
Yeah, you would have to take a wash and measure with antibodies. Yeah. It's harder. Yeah. Okay. All right. So then they asked, what about T cell responses? 25 and 100 microgram doses elicited Cd4 T cell responses, which on stimulation with peptide pools specific for the S protein were biased towards expression of Th1 cytokines. And they say minimal Th2 cytokine expression. So, Brianne, what does that mean that we have a bias towards Th1?
So with your CD4 positive T cells, there are different types. The first two described were Th1 and Th2, and then immunologists, I guess, forgot how to count because they started to be all sorts of other numbers.
They do. What came after 2? 17 or something like that?
So there was one type that was called Th3 for a little while, but then it got renamed, and then 17, and then 9. So there has been some previous sort of hypotheses that some vaccines may lead to some enhanced responses that are causing problems. And those problematic responses were largely Th2 driven responses. And so they really wanted to see here if the T cell responses tended towards the Th1 type of CD4s or the Th2 type of CD4s. Those can be distinguished by the cytokines that they produce.
Now, is this effect with the Th2s, would that be something like the antibody-mediated enhancement you see in dengue, or?
The way they've described it here is not exactly like antibody enhancement in dengue. It's more specifically that the Th2 cytokines are causing pathology.
Right. Okay.
But you could imagine a few different things going on there, causing these effects. And so they look at both Th1 and Th2s and see more Th1s, and they also see that the T cell responses increase pretty dramatically upon the boost.
Mm-hmm. So the Th1s are going to be involved in generation of CTLs, right? Cytotoxic
the Th1s are going to be helping make good CD8 killer T cells.
So,
the killer T cells, just to fill in the blank here, are going to go patrolling around looking for virally infected cells and killing them.
Exactly.
So my question is, why isn't the spike giving you Th2? Why isn't it leading to antibody preferential? Is that typical for a spike, or is it not? Is this unusual?
I don't know about the spike specifically, but the thing that I would want to know more about is about the nanoparticle formulation. Mm-hmm. And whether that is biasing towards a Th1 versus Th2 response.
Because I think, if I remember correctly, Udell wrote that if you put nucleic acid, you should get
a CT8.
Is that right? What he said? Yeah, CD8.
My understanding is that you ought to get both.
Yes.
Right, with a nucleic acid. And they say that, did they actually say it's biased towards Th1 response? I mean, it doesn't mean that obviously they're getting antibody made.
Yeah.
Okay. They're getting both arms of the response.
They see very little Th2 response at all. These Th2 responses are quite small.
All right. So here's what John said. He said, nucleic acid-based vaccines will induce B cells, CD4, and CD8 T cell responses. But he doesn't say anything about Th1 or 2. Okay, so I don't know what you would expect. I mean, CD8s or CTLs are good to have, right?
They are. And they also do show their CTL responses in the supplemental figures, and they don't get huge CTL responses here. It's really just the Th1s.
So, in fact, Brianne, most of this paper is all about the neutralizing antibody response, which, as they say, we assume this is what is going to protect people. But in fact, they have a paragraph on the T cell responses, and I guess it's because we really don't know anything, because they actually admit we don't know what the correlates of protection are. Yeah. But we're assuming that it is the neutralizing antibody, right?
Yes. In fact, when I read that part of the paper, I felt like part of it maybe read like something that had been put on a little bit later with reviewers, and my response was, sorry, guys.
So, Brianne, when the cytotoxic lymphocyte finds the infected cell, is it not, or is it antibody mediated?
It is not antibody mediated.
Okay, because there is a type that is, correct?
There is an antibody mediated killing that involves something called a natural killer cell.
Right.
But when the CD8 T cell, the killer T cell, does its ability to kill infected cells, it is not mediated by antibodies.
How does it recognize the infected cell then?
So the infected cell has a protein on its surface called MHC.
Oh, okay.
Which is presenting or showing a piece of the viral protein.
So my understanding has been, my sort of superficial understanding has been that, and I guess this is what you were talking about at the top of this, is that if you have an immune response that's totally biased towards Th2 and primarily just an antibody response, that historically that's associated with some problems with the vaccine, the enhanced disease and stuff. And so having some Th1 bias and some killer T cells around indicates that you're in this more in the safety zone relative to those problems.
Exactly.
Right?
And whether a Th1 or Th2 is sort of problematic or whether it's protective really varies from pathogen to pathogen.
Right.
Yeah, they actually.
But these results they look good. They're reassuring to see this profile. Yes. This is pretty much the profile we'd like to see at this stage in a vaccine.
But what they don't tell us, of course, is whether these responses, these antibody levels, are durable. Because they're only at day 57, and we're going to find out. And I will bet that they will go down pretty quickly, but we'll see. I just don't see why they would be sustained.
Yeah, go ahead, Brianne.
If you look at table 2, where they show the actual data, in the ELISA, even between day 43 and day 57, it looks like the value is starting to go down, even though the confidence interval makes it hard to say that that's really significant. The overall value is actually getting a little bit less even by day 57.
Yeah.
So Jason had an interesting spin on this last night, and I haven't looked up the paper that he talked about that I should, where measured in COVID-19 patients antibody response and durability over time. Apparently, this has been going wild on Twitter, this particular
it's in my
paper.
Bookmarks to read.
Okay, and showing a decay. Okay, and there's been a lot of discussion about how they drew the curve and all that kind of stuff. But Jason's comment was, this is what's supposed to happen. Okay, you can't have high levels of antibody to every pathogen you see all the time.
Right.
The normal situation is that there is at least some decay.
That's true.
All right, down to a baseline, and then memory is what becomes important. I suppose the real question is how much decay is there and how much is tolerable. And so what 3 years out, what should be there? I don't have an answer to that.
And you want to make sure that the cells that persist are good memory cells that are able to divide and act quickly upon restimulation, not sort of mediocre memory cells.
So, Brianne, can you imagine a situation, is this reasonable, where basically the circulating antibody would go down to something that was hardly even measurable, but you would have a persisting memory response that was good enough so that if you got infected, you'd be okay?
Maybe. Right now, we usually seem to be able to measure those memory cells a little bit better. And so we probably should be able to see an enhanced memory response, although it won't be as high as it was at the beginning.
So when you measure serum antibody, that doesn't tell you anything about how many memory cells you have around, does it?
Not at all. So you need to actually look specifically at the B cells.
I remember.
What about the CTL cells?
The same thing. So you're going to make up a whole bunch of B cells and CTLs that are going to respond during that first encounter. They'll divide and divide and divide, but then most of those cells are going to die, only leaving behind the memory cells. And that's a really good thing, because if you think about how many infections you've had over your whole life, if you kept all of those newly divided cells, you would be a walking lymph node. You would have no other
cells.
Yeah, you would just be a lymph node.
I once saw a brilliant lecture on this, that really drove home that point. Basically, the deregulation or deactivation is every bit as important as the activation.
No
Otherwise, what you're talking about, if that craps out, you're talking about a lymphoma, right?
Yep.
Yes.
And there are some autoimmune diseases.
The key here is some of the patients who have been studied, that goes down to undetectable levels. So I agree, you don't want to maintain high levels of antibody. However, what is known for SARS-1 is that the T cells can remain for 17 years. You can find virus-specific T cells. You may not find antibody, and maybe those are going to be important. I keep bringing this up that people are not paying a lot of attention to those. They're measuring them, and then that's it. But it could be that they're really important. So they say here that they like the 100 microgram dose, and they started phase 2 in 600 adults already, and phase 3 is beginning now. Is that right, Alan?
Yes, my understanding is that phase 3 is supposed to start by the end of this month.
The enrollment start date is, I've been looking into this. The enrollment start date is July 27th. They're enrolling 30,000 people. It's happening at 87 different sites in the U.S., including Austin, and I signed up last night.
So this is the...
We'll see if I hear back from them.
100 microgram dose twice, right?
Correct.
10,000
they also
people,
say,
said, right?
Excuse me?
You said 10,000 people?
30,000.
30,000.
So of the phase 3 trials that are going on, this is by far and away the biggest. This is huge.
Yeah, they're putting a lot of eggs in this.
This is bigger than the Oxford trial?
Oh, yeah. The Oxford trial is only like 8,000 or something like that.
So, Alan, how long will it take to enroll 30,000 people?
Months.
And by enrolling,
87 sites.
By enrolling, so, we just mean that we take your name and
yeah, well,
we don't inject you yet, right?
There's a whole there's a whole process. So let's say Rich gets the call. He put his name in, and they call him, and he's going to have to go into some kind of a preliminary screening appointment, and they're going to ask him.
Take one look at me and say, "Take a hike."
Yeah, I agree.
They're going to find out what his background is and say, "You're a virologist." No, we don't want you. They're gonna screen him for other conditions because they don't want people who are super sick. They don't want people who are going to be throwing their curves off. But they're also going to want to make sure that they get the right, what their statisticians told them was the right distribution of age groups, and they don't want everybody in the trial to be in Austin. They've got 87 sites, so they've got to balance the sites. So there's this whole thing that has to happen, and I can't say how long it's going to take under the current circumstances, because Defense Department quantities of money are getting thrown at this, so that's already accelerated things. And it's possible that they could get everybody enrolled in a couple of months. And then they have to bring Rich in and give him the shot. And then they've got to bring him in a month later because it's this 2-shot regimen and give him another shot.
They're probably going to take my blood and stick things in my nose.
Blood samples and SARS-CoV-2 tests at each of these and the whole bit. And then after they've done the 2 injections separated by a month, then they've got to just wait for people to get exposed to the virus, which in Texas is a pretty increasingly likely event.
I'm going to run right out to a bar.
Yeah, exactly. I assume they have sites in Florida and Arizona. If you did this in Massachusetts, you might be waiting forever for people to get.
That's a good point. So, they probably will counsel you to maintain social distance, physical distance, and wear a face mask. However, they're counting on people not doing that.
They're counting on people getting infected. Yeah. Well, they're not counting on people not following the recommendation. They are counting on some of the population getting exposed and infected. And they're going to vaccinate. They'll vaccinate people from all walks of life. It won't just be people like Rich who are retired. It'll be the grocery store clerk and the people who have to be out and about, and the paramedic and the cop whose PPE consists of non-latex gloves and a Glock 22, who we heard from, right? So there are people who are going to be exposed to the virus, and then they'll wait probably a few months it's going to take before there are enough cases in their control arm and in their dose arm for them to say, okay, this vaccine is actually working, or to conclude that it's not, because you just have to wait for these natural infections to occur.
And remember, the FDA said they will approve anything, 50% efficacy or above. So that's the cutoff. If this is 51% protective, it will be approved, but 49% of the people who get it are not going to be protected against what? I don't know. Maybe just serious disease. Who knows, right? I don't think any of them will be protected against infection, most likely.
Right. And that's another thing. As people get infected, they're going to have to bring them in, test them. I'm sure there will be regular testing of the people who are enrolled in this. Did they get infected? if they got infected, did they get sick? If they got sick, how serious was it? And this is going to have to be collated.
And of course, there's a control group who gets just PBS, and they won't know that because it's going to be blinded, double blinded.
Okay.
Actually, I think in the first round of this, they gave them meningococcal vaccine so that they get,
they do get an antigen. Yeah.
They so get an antigen. Some soreness at the injections.
Yeah, exactly.
Well, and that's also, you'd hate to do a vaccine trial and say, oh, hey, it had some benefit, and then find out they would have had the same benefit if you'd given them all a flu shot.
Yeah.
Right. It could just be a generic, and we've talked about this phenomenon on TWiV, where you get a generic boost in immunity, and that could prevent some infections just by itself.
So the other thing that interests me about this is the RNA production. So Moderna is in cahoots with a Swiss pharmaceutical group called Lonza that has outlets or factories or whatever, I don't know what to call them, all over the place. So that it's the headquarters is in Switzerland, but I gather that most, if not all, of the actual RNA production and vaccine formulation is going to be done for this trial in the U.S. They already have enough stuff ready to go for the phase 2 trial. And as we have described before, part of this boost in funding is to, and accelerating this whole program, is that they're already anticipating that this is going to work. So it's what Jason called at-risk production. Okay, of distribution quantities of vaccine, and they say they'll have enough for 500,000 doses by the first of the year, or at least in the first quarter.
Not a lot of doses.
It's not so much that they're assuming it's going to work. It's that they're.
Did I say 500,000?
Yeah,
500 million.
Okay. 500. Right.
That's bad.
So, and it's not so much that they're assuming it's going to work. It's that they know that somebody else is going to pick up the tab if it doesn't.
That's what Tony said.
Right. So Tony talked about this. They're doing it at risk of the money because the government has stepped up, and said, okay, we're going to put B-1 bomber size budget into this and say that you can ramp up production and we'll pick up the tab. And if it doesn't work out, we eat the cost, and the Moderna doesn't have to do that.
So that's, I did a quick calculation while I was out walking today, and I probably ought to redo this, but I figure that's 50 kilos of RNA. And if they're talking about 500 million 100 microgram doses, that's enough to vaccinate 250 million people, because we got to do a prime and a boost. I'm assuming that I'm making the right assumption.
50 keys, man. 50 keys.
Yeah, 50 keys. Just put it in the trunk of a Chevy and
50 bricks.
So it's all pretty interesting. So, the acceleration of the timeline here from years or decades down to a year and a half, I'm blown away. I never thought that this would happen. This is I'm really blown away. And
it's all about the priorities.
Yeah. And about money.
Yeah.
But it's technology. Yeah. I mean, the speed here is, in my mind, two things. One is the technology. Okay. Because I mean, there was a pre-existing knowledge, but sequence to a candidate is like weeks, given the technology platform. And so that cuts out years of goofing around. All right. And then they're like telescoping a lot of this process, doing the at-risk production, overlapping some of the trials. But at the same time, I don't think that they're sacrificing any of the safety issues. And the FDA has said, we aren't going to skimp on any of the safety stuff. So all these trials are going to be done the way trials are done. It's just that they're telescoping a lot of the stuff and anticipating the next step, having stuff ready. So that speeds everything up.
And because the money and manpower is available, and the technology is part of it, but I would like to point out that there are lower tech vaccines that are equally far along, and one of my favorites is just like philosophically favorites is the I think it's Sinovac has an inactivated vaccine, which is the simplest way. I mean, it's just like you take the virus, you grow up tons of it, you inactivate it, and that's your vaccine. So yeah, it's awesome that you can go from sequence to picking the ideal structure and get all this information, and then go to growing up RNA, and you've got these nanoparticle encapsulated RNAs that are going to be the basis. That is all awesome. But then at the same time, you've got efforts that are, give me a fermenter and a Bunsen burner and a hypodermic. You know, it's just like that also could work. It's not quite that simple, but yeah, it's really about this this telescoping, as you call it, this parallel action that's going on. I just want
to point out that 57 people is not a lot of people.
No.
When you think about how many people this is going to go into. So the safety has to continue to be evaluated. It's not over.
No, and this is not over with these 57 patients either.
No.
They are going to keep looking at these patients.
Yeah, but 57 is a genetically very restricted representation of the U.S. population. So maybe when you put it in 10,000, then you start to see these outlier effects that we can't deal with.
Or maybe you'll find out that in people over 60, it doesn't produce an immune response.
That's why
which is like should be your target audience.
No, be patient, folks.
There's a lot that can go wrong.
And
so who's covering the insurance?
Of what?
Of something that can go wrong.
No, I don't know.
I remember
it's a good question.
The outbreak. Yeah, it was important because in the old days when I guess it was Merck was involved in the development of the swine flu vaccine from a case that occurred in Fort Dix, New Jersey at a military base. Someone developed Guillain-Barré syndrome, and then another person, then another person. Pretty soon it was a very serious side effect of this vaccine. And the government picked up the tab because Merck, in its infinite wisdom, had negotiated that small detail with the government before they started.
I am 110% certain that Moderna's lawyers have inked something very,
of course
very
they have.
similar.
Of course they have.
Or Moderna's lawyers need to be fired.
This is why I asked the question.
Well, there is also, I forget what the name of it is, and somebody may write in with this, but there is also an ongoing government insurance program, essentially for exactly this, so that the vaccine companies are not at risk. It takes some of, if not all, of the liability off the vaccine companies.
Moderna is in cooperation with the NIH anyway, so it's automatic.
So that may sound to the conspiracy theorists as some sort of government thing to let the big bad vaccine companies off the hook, but the fact is that if they have to shoulder all of the liability for everything that could go wrong, they can't function.
There would be no vaccines, and the way the vaccine court works, as it's sometimes called, is it is a specialized court that hears these cases and that is adept in handling the scientific complexities and the nuances and the subtleties of vaccine complications, which can occur. But if you put this into the regular court system and had juries who have no idea what's going on, listening to arguments from motivated attorneys, you could have all kinds of absurd settlements coming out that would just, there would be no vaccines if it wasn't for this.
So the problem with these specialized courts is that the payout is very low. I mean, I know.
Well, compared to the $1 billion verdict you can get for spilling hot coffee on your lap, sure.
Well,
that's
glyphosate.
You will get
weed killer
for the polio vaccine era when people used to get paralyzed from the vaccine. You could get a few $100,000 from these specialized courts, or you could get $20 million from a regular court. So a lot of people bypass their right to go to those specialized and did a regular trial. I know because I was an expert witness for one of them, and I was explaining about poliovirus vaccines and neurovirulence, and most of the people in the front row of the jury were sleeping. Right? And the guy
paralyzed by your talk.
The guy ended up getting $20 million.
Wow!
Even though there was nothing wrong with the vaccine.
But who did the $20 million come from?
No, the manufacturer, of course.
Really?
Yeah. Anyway, if you'd like the details about this phase 3, you can go to clinicaltrials.gov and you can find out exactly what they're doing.
Yes.
The ages, the placebo, et cetera. All of that is detailed very nicely there, much more than we have time to go into. Now, the other paper I wanted to bring up and is very interesting. It's an article in Nature. It's called Open Safely, Factors Associated with COVID-19 Death in 17 Million Patients. So this is a study out of the
UK study, right?
UK. Yeah, we have University of Oxford. We have London School of Hygiene and Tropical Medicine. We have the health organization, NIHR, Health Protection Research Unit. And what they did was say, okay, we have all these computerized information about all kinds of information about patients in the UK. In fact, 17,278,392 records. And we can say of those, who died of COVID-19 and what other things did they have? And you can imagine.
Because they have a National Health Service.
Yes.
With electronic medical records.
That's right.
They've got this database that they can harvest these data from.
Yes. So then you can not only harvest it, but you can then say, all right, let's control for this, or let's see if these people had this or that. You can do all kinds of things because you're sitting at a computer and just chugging through. Wonderful. Very cool. So of these 17 million, 10,900 had COVID-related death. And they say, what kind of factors? And so, for example, men had higher risk than women. Well, we knew that from what we've talked about here on TWiV already, but confirmed in this. And all non-white ethnic groups had higher risk than those with white ethnicity, which we also either knew or suspected as well. And it's partially due to greater deprivation in those groups.
I would like to hear deprivation defined. I don't know if they define. I'm sure they've got some official definition for deprivation.
Yeah, they don't. And after reading through the entire paper, I decided, using my context clues, that it was a socioeconomic status thing.
Yeah, something like that.
It's not well defined.
Yeah.
Yeah.
Yes, it is not oxygen deprivation. It is financial and social.
Right.
Access to healthcare.
And they have levels. They've got 5 levels of deprivation. Yeah. So they've obviously got cutoffs for this somehow. I don't know. I think
this may be some established term of art in the UK.
Sounds like to me.
The social science, so
that's right.
They're not defining it because everybody knows what we mean. We're using the deprivation index. But
the way you can do with computerized data, they can say, okay, so is it really deprivation or is it comorbidities? And they say, no, it's actually not other diseases. It's the social factors themselves that are associated with death in this particular population. Another risk factor was obesity, diabetes, asthma, respiratory disease, chronic heart disease, liver disease, stroke, dementia, neurological disease, kidney function, reduced kidney function, hematological malignancy. All of those associated have a HR. What does the HR stand for again?
Hazard ratio.
Hazard ratio. Higher hazard ratio in these deaths. Then they looked at smoking. It's an interesting situation with smoking here because you would expect that smoking would lead to higher risk. But they say we can't really say that because there are other things that predispose people to smoke, and it may be those things that are actually making these patients at risk. So they try and sort that out, and they can actually separate them. So there's no effect of the smoking on its own doesn't have an effect, apparently, when you separate it from all these other things. Any increased risk with smoking is probably small. And they have this sentence about a possible protective effect of nicotine, I guess, which people have suggested, but they say they don't see that in any of this. The other comorbidity is hypertension, which is associated with higher risk up to age 70, but lower risk at higher ages. And they say, go figure. We don't know what's going on there.
Yeah, they say go figure. Yes.
So, I mean, these are the things you would expect would be risk factors for death, I suppose. But the numbers here, and they're going to get bigger and bigger, right?
How about obesity?
Yeah, obesity's there, sure.
Yeah.
And high blood pressure.
Yep.
Yeah.
That's hypertension, Dixon.
Yes, sir. Yes, sir.
Did you turn off the speakers for a minute?
No, I didn't.
Okay.
I'm curious to go back to the deprivation event. Are there no poor white people living in England?
Oh, there are, but statistically, they're not. If you're white, you're less likely to be in the deprived group than if you're. If you're.
I have a different question, Alan. If you're in the same socioeconomic group,
right,
and you're white, what's the death rate?
They actually looked at that. They separated out ethnicity versus deprivation,
yes.
And they saw that both deprivation and being in different ethnic groups were both risk factors, independent of one another.
Right.
What I am interested in knowing is why, or what's the mechanism?
Sure.
What's the mechanism for obesity being associated with hypertension or heart disease? What is it? I mean, people say, yeah, of course it would be, but why? What's the underlying mechanism?
I bet the link in all this is going to be inflammation.
Yeah.
I think so. There's mounting evidence that this condition that's sometimes called diabesity or globesity or this pandemic of bad health that we have worldwide is very tightly linked with a chronic low-level inflammatory state, and that's caused by and also helps cause this set of metabolic symptoms. Similarly, hypertension, there's associated inflammation, and all these other conditions, there's going to be some kind of inflammatory mechanism going on. And I think that's all what's raising people's risk in a disease like COVID-19, where the immune response is what's going to end up killing them. Because the people who mount a successful immune response and then successfully tamp it back down again get over this disease. The people who can't tamp it back down again end up on the ventilator or end up dying. And I think that's going to turn out to be the link. And it could explain the ethnic difference as well, because chronic stress, with or without deprivation, is going to increase chronic low-level inflammation. And people in discriminated against ethnic groups are under chronic stress. And so I think that's going to be, that's just my way of framing the whole thing. But
that's exactly my thoughts as well. I have a slide in some of my research talks where I'm talking about why is it important that I'm studying this aspect of inflammation, where I show that 9 of the top 10 causes of death worldwide all have inflammation as a component.
Well, it may explain also why dexamethasone and immunosuppressants are helpful later in infection as well.
And aspirin therapy for preventing heart attacks, et cetera, et cetera.
Okay, let's read some email.
Uh-huh.
So we had a few responses to the upset Chinese listener. So first is from Lisa. Thank you very much. Without it, a layperson like me has almost no chance of finding logical and scientific information about the pandemic. I want to thank Dr. Raccaniello for defending the Chinese scientists in the Wuhan virology lab. You have done more to dispel misinformation. When you were discussing how the virus could have been picked up by someone unknowingly, it made so much sense. That discussion reminded me when I was little, I once found a bat by the foot of a tree in the schoolyard. I thought I would save it and took it home with me, completely unaware of the potential danger. I was lucky and no harm came from it, but it could very well have been disastrous. I was also unable to save the bat in the end. I'm Chinese, but not currently living in China. I can only speak for myself. I do not feel that any member of the TWiV team has been culturally insensitive in your discussions. The only people who are culturally insensitive are the people in the media perpetuating the falsehood that the pandemic is caused by Chinese people habitually eating bats. I wasn't even aware that bats were being eaten until I heard it on the U.S. news stations. Now I hear stories that Chinese people are being yelled at, physically attacked in the U.S. and Canada, which is a shame. And I will skip some more here, and I will go down to Professor Condit didn't need to feel bad about his comments. In truth, the first thing that came across my mind when I heard an experimental vaccine was given to the Chinese military was that the Chinese government was using the soldiers as guinea pigs. I don't believe it is due to an unreasonable cultural stereotype. Many Chinese people will have the same suspicion because we know that the government does not value individual citizens' lives. We were taught since we were little that all citizens should sacrifice themselves for the good of the country and the party. So if the government was using its citizens to test experimental vaccines, most Chinese people would not think it was wrong to do so, especially in this case where the safety has already been established. Soldiers that were selected would very likely feel it was an honor to be able to make such a significant contribution.
The attitude in the U.S. is somewhat different than that.
Oh, yeah.
Very interesting. The cultural differences are very interesting.
Yeah, I should have read that part. Ironically, many in the U.S. don't seem to think that differently anymore, as a number of politicians are telling the public that they should sacrifice their lives for the economy. Okay. Let me see here. I love it when Dr. Racanello goes on a rant about some injustice he sees. Thank you very much. It's called rack and yelling. Free speech is a wonderful thing, and most people are in the world do not have it. It's also more fragile than most people realize. It worries me when I see that scientists and intellectuals are being attacked by the current U.S. administration and also by certain people of the extreme left or right. People often compare Trump to Hitler, but I think it's wrong. I see a much stronger parallel between him and Mao Zedong. Mao attacked the scientists and intellectuals in the Cultural Revolution, dismantled the entire Chinese education system, and turned the masses against higher learning. Being uneducated became one's ultimate achievement. Similarly, the cancel culture that is developing in the U.S. universities also reminds me of the Red Guards, students who denounced and attacked school administrators and professors. I hope my worries are overblown. However, I think in order to protect free speech, scientists cannot stay out of politics. Quite the opposite. Scientists should get more involved and need to speak louder than the voices of ignorance. I hope you will encourage your students and colleagues to get involved in politics, run for office even. There's no reason why U.S. leaders should only be lawyers, business people, and actors. Your podcast feels like a life raft in an ocean of crazy. Thank you very much. A very thankful listener who happens to be Chinese. Thank you very much. Cancel culture, huh? That's interesting. Alan, can you take the next one?
Yes, I am.
Can you take the next one? Are you able to take the next one?
Alan, now that you no longer have a guest.
That was Oliver, by the way. Okay, so I'm up to Stephen.
Yeah.
Okay, Stephen, dear TWiV, a longtime grateful listener, once happily retired physician until recently COVID-19 happened. Oh. I'm still feeling disturbed by the recent listener email on TWiV 638, which was inevitable. The long-standing cancellation culture nonsense endemic on social media washed up on the pristine shores of the TWiV intellectual landscape, thus truly becoming a pandemic itself. No one has been more culturally sensitive and aware than Vincent, Rich, Alan, and the rest of the panelists. Lest we forget, in the early stages of the Wuhan outbreak, local public health physicians were silenced and a few jailed for speaking out about the outbreak.
It's true.
Until the problem got so large that the local Wuhan and Beijing governing forces were forced to admit a problem existed and start taking measures to control it. Valuable time and lives were lost during this period. That afterwards the central government became open and more transparent should not erase the facts of this earlier period. Your comments on the administration of the vaccine to the Chinese military were intellectually proper and morally warranted. Stand proud, TWivers. We need you on that wall. We want you on that wall. The only antidote to this nonsense is zero tolerance for this bull. Vincent, stay grumpy, stay brilliant. Sincerely, Stephen. P.S. I will be more culturally tolerant when the Chinese government releases the more than 1 million Uyghur Muslims and their families being held in re-education concentration camps in the western part of the country.
Okay, Brienne.
Yes. Yuan writes, Dear TWiV organizers, I was in the middle of TWiV 638 and was furious when I heard one Chinese complaining about your recent comments on the Chinese vaccine and the military story. I just want to email to show my support. That one Chinese person doesn't represent most other members of the Chinese audience, at least not including me. I came to the US for a PhD about 10 years ago and am now studying endogenous retroviruses as a postdoc in CU Boulder in a lab descended from the LD lab. TWiV was recommended by my PI about 2 years ago when I started long commutes from Denver to Boulder, and I have since become a TWiV fan. When I heard that some of you were going to Fort Collins for the ASV meeting, I told my boss that I wanted to see you guys like fans going after pop stars, even if I wasn't planning to register for the meeting, because I didn't really have a virology project at that time. Of course, the meeting was canceled, unfortunately. My school was locked down in mid-March, and I have since started listening to TWiV nonstop outside my car when I was cooking or taking a walk. I want to acknowledge the fact that in the podcast, you constantly defended China for the virus source from the Wuhan lab or the Chinese virology scientific community as a whole. Despite not being very active in social media, I shared the TWiV special, Conversation with a COVID-19 Patient, Ian Lipkin, aired on March 28th on my Facebook and Twitter, because I want more people to hear how Ian interacted with Chinese virologists in the early days of this pandemic. Another story I want to share is what I've done during the lab lockdown. Because of the pandemic and the lab lockdown, I was actually not very motivated to work on my computational project or proposal writing that I had agreed to my boss in the beginning. Because of TWiV, I was following the cutting-edge COVID research, and in the middle of the pandemic, I came up with a computational coronavirus project that had nothing to do with my previous projects, which I felt more motivated to work on. Sorry for this long email without a real question, but I want to show my support as a Chinese researcher living through this pandemic in the US now. Keep doing what you have been doing, and I hope one day I'll be able to meet my stars in person. Best, Yuan.
Thank you. Thank you so much. Thank you all for your support. We appreciate it.
Absolutely.
Dixon.
Yes, sir. Okay, I get the performance part of this show, I guess.
Good. Get it right, Dixon.
Right. Language is my weakness. It's mine too, by the way. This is my first limerick. I hope it brings you a chuckle. If I broke a limerick rule or two, so be it. I don't think you did, actually. I read this one. There was once a new virus plight that proved our politicians not bright. They listened to heads phony, not to the very wise Tony, and now we are in a terrible fight.
Well done.
I was thinking of reading.
I love it. I love it.
Rich, I was thinking of reading that to Tony yesterday.
Let's send it to him as the thank you note for being on the show.
I have ordered a Tony Fauci bobblehead.
I was thinking about it.
That hasn't. I mean, they're probably back ordered for 10 years, so I haven't got it yet. But I wish I had it. I would have had it.
No, I think we should start
on my desk.
Start a project to go down to Tennessee and change that icon that's etched into the mountain and make it Tony Fauci's face.
There you go.
Good job. Rich?
I do have a Tony Fauci t-shirt.
Oh, yeah? Cool.
Yes, it says, "Help us, Dr. Fauci. You're our only hope."
Ah, very good.
From Star Wars.
That's
nice.
great.
That's great.
I like that. Rich, you're next.
I love this letter. This is great. Michael writes, "Dear members of the TWiV team, my first official letter to TWiV. You guys are great, and there's not sufficient time to praise each and every one of you for the work you do on TWiV. I'm writing to comment and share that I literally did a spit take onto my poor unsuspecting iPad when I heard your discussion on TWiV 637, letter from Jonathan in Sweden, that brass instruments should be made of copper, as you were discussing the SARS-CoV-2 output potential from the spit valve and the horn bell from the brass instruments. The spit take occurred whereupon I began shouting at the iPad, 'Brass is copper.'"
Sorry, you're right. I forgot. My fault.
Brass is an alloy, and then we get this. This is great. Brass is an alloy. This is TWiV, dudes. Brass is an alloy of copper and zinc two transition elements, where copper is the bulk element in the alloy, and the zinc is added to confer mechanical and strength properties, but also enhances its antimicrobial aspect. The alloying process is effectively creating a new metal, brass, a substitution alloy where the atoms of the two elements may replace each other in the same crystal structure. The consequence is, yes, this new metal is a recognized antimicrobial material with an ability to achieve a public health claim by the U.S. EPA. The brass serves to generate free radicals in concert with moisture and oxygen to create singlet oxygen and other free radicals as an electron sink. There you go, folks.
A lot of doorknobs are made out of it.
This is great. Oh, yeah, good point. The consequence to the unsuspecting SARS-CoV virus entering the labyrinth of a horn's plumbing is first damage to the envelope and then destruction of its message as the virus exits the spit valve or horn bell. Silver instruments are not as good unless they're polished. And on the inside, this is unlikely. So if the instrument is made of silver, it will passivate into a form of silver oxide that is not antimicrobial. Silver products out there that are antimicrobial accomplish this by complexing the silver ion to EDTA, and upon interacting with human sweat or sodium or potassium ions, displace the silver ion and then react with the proteins in the outer membrane and the inner membrane, rendering them inactive and hence death and destruction. Keep up the outstanding work and someday. I hope TWiV can get to episode 1000. Your likely target before the end of the year. At that rate, you contribute producing this outstanding podcast. And of course, this is from Michael G. Schmidt, PhD.
Dr. Copper.
Dr. Copper. This is great.
So apparently then if you're playing a brass instrument, you could let the spit come out, right?
Good.
Well, we don't want to go making that recommendation specifically, but
no, we don't.
But brass is copper, and it has the same antimicrobial, if not better antimicrobial.
One would have to test it and make sure.
Like
a parachute, nobody's going to do the control.
I would still say that a brass recital with your friends is going to be a high risk event because the droplets that don't contact just go straight through. That's
true.
Yeah, there's a lot of breath that's not going to contact.
There's a whole lot of breath going.
But I do appreciate the correction because I got it wrong. Sorry. Thank you, Michael.
That's more metallurgy than I've learned in my entire life.
It's great. It's just great. Alan, do you want to say goodbye, or you want to?
Yeah, I should probably go ahead and sign out now. But it's always a pleasure.
Yeah, Alan Dove is at turbidplaque.com. He's Alan Dove on Twitter. Thank you, Alan. See you next week.
Thank you. Take care.
Happy trails.
Stay safe.
It would be really weird to go back to all audio. I've gotten used to looking at you guys.
You don't have to.
I don't want to do that.
We don't have to. I had always planned to one day make TWiV video, right? And I was always like, how can I convince those guys to do it? They're not going to want to be on video, blah. But the pandemic automatically did it. You guys are used to Zoom. You have no second thoughts about it. It's great. True. So it did it for me.
Have you ever considered just putting the video up and don't do anything to it? Just put it up.
What do you mean just put it up? I put it up. I do put it up.
Unedited.
No, I would never do that. I don't do that. I make it high quality, Dixon. I have production values. Do you know
some
what
of the outtakes are high quality?
No, I don't do a lot of editing.
It's true. I've learned how to mute my microphone.
In fact, that's actually something you have learned since the pandemic, to mute yourself, because Zoom makes it very easy. Right, Dixon?
Right, Vincent.
So far this episode, there's nothing that I need. I would just cut the beginning off where we're jawing, and I stick the music on, and then at the end, the only time I would edit it is if there's a big gap where no one says something for 10 seconds. I don't want that in there.
Has this made your life easier?
No, it's made more work for me.
Oh.
Yeah, because you post now the audio and the video.
Yeah, I do both still. I mean, the audio still goes up, and then I do.
All right.
But the thing
maybe
that
I'll wear a shirt next time now that I know people are watching.
people have been watching for a few weeks now, and we have on YouTube. These things get 10,000 downloads, which is not big in the YouTube verse, but ain't bad. On top of the audio,
it's not bad at all.
But what I do record the audio separately, and so Zoom records the video, which is low quality. It's not great, but it's good enough. But their audio stinks. So I actually replaced the Zoom audio with my local recording here.
So you have to lip sync everything in there.
Yeah, and then Zoom drifts. It's got this weird drifting, right? So I have to go through and check your lips and move things around because periodically, although the Tony Fauci one yesterday had no drift whatsoever. I guess it's a government.
Even Zoom knew that.
Even
Get
Zoom.
your act together, Zoom.
Yeah. So I very much enjoy the video, and I think with guests, it's great. You can see your guest there. And,
we totally agree.
So it will keep going. And, I have to say again, it was a boon because I wasn't sure. Skype video was always wonky, and I was not sure how it would work out. And I just imagine Kathy saying, I don't want you to do video, but she loves it.
Right.
And I've heard from a lot of listeners who really love it too.
I like to watch this, but you know what the funny thing is, Dixon? You'll appreciate that. Yesterday when we recorded Daniel, he said, I don't want to wear headphones anymore. I look too funny. Isn't that funny?
He looks perfect.
Yep. His sound was fine without headphones, but most of the time I want people to wear headphones because if you have the sound coming out of your computer, it's going to go into your mic and make an echo, and it's not nice.
Right.
So that's why all of you guys have it. Okay, here we go. Back to science. Sam writes, Hi all. It's a crisp 16C here in Nashville, Tennessee.
Uh-huh.
All right. I'm a graduate student working in a virus innate immunology lab and much appreciated the shout out to the innate immune system in episode 597. Oh, man, that's like 50 episodes ago. Holy
I
cow.
shout out to the innate immune system every day.
You can tell by the Celsius, 16 degrees Celsius. Come on.
Thankfully, with this being my interest, I know what sources to trust with respect to information on this pandemic, how to interpret the majority of science jargon that often comes with it. Unfortunately, the same cannot be said of my parents and a lot of others I see on social media, claiming that they all look at the numbers and only speak data. It is still believed that restrictions related to this pandemic are a gross overreaction. Oh. Since Ohio isn't the same as New York, they shouldn't be expected to stay home. They should instead lock up the elderly, immunocompromised populations and be able to go about their lives. I try to explain rationale and even the science behind the infection as much as I can. I even refer them to your podcast and other sources to help point them in the right direction. Nothing seems to get through. However, the most frustrating part is that they are representative of a large portion of our population. How do we better reach those that are so misinformed? Unfortunately, they are not quite on board with listening to a 2-hour podcast, nor are they willing to truly understand and internalize the science that I'm telling them. I would love if maybe after each one of your shows you could post a facts at a glance sheet, which summarizes some of the more important things that you've learned from your guests. So, in fact, this was requested some time ago, and I asked Kiki, and she has somewhat irregularly produced Kiki's comments, which is a summary of each episode, and they're posted in the show notes, microbe.tv/TWiV, Kiki's comments. Now, it's been a while since she did the last one, and I understand it's hard because you have to listen to the whole thing and take notes, and she's been very comprehensive, but if that helps, there you go.
This is a very similar letter to the hairdresser's letter.
Yes.
Frustration with trying to get people to be reasonable about this, it's the same issue that we deal with anti-vaxxers and the rest. There's a lot of people who really resist genuine critical thinking. And if there's anything we can teach on this show, it's how to think critically, how to say, oh, I was wrong.
I mean, the point here is that we have a conversation and we work things out, and you could learn from just how we're dealing with it, right?
That's the process.
It's the process.
I know that we've done that on masks. I know that in the whole conversation with Michael Mina that we had earlier this week, I wasn't very excited about group testing, but when I saw his data and heard him talk about it, I was like, okay, yeah, this makes a lot of sense.
For sure.
And that's the process that people should be following here.
I've turned a lot of corners since this started. When it started, I thought it was no big deal. It's not going to spill out outside China. Then I thought, well, it's not going to be any worse than flu. I thought that masks weren't a big deal. I figured we'd never have a vaccine. I've been wrong at every turn. Okay. So
how could you be right? If you see the Tony Fauci interview, you'll recall, and of course you were part of it. He said, a lot of people ask me what I think. I said, I don't know. And then they say, well, what do you, what would you imagine? Something like that. And he gives them an opinion and he says, after he turns out to be wrong, I knew you were wrong.
Yes.
They're just looking for a way to find something wrong with what he says. And that's really too bad.
Brianne.
Tommy writes, TWiV noob here. I know what that is now because I have a gaming chair. I'm an engineer who went no further than high school biology, so be gentle. I was wondering about the balance between T cell defense and antibodies. Is it possible our use of vaccines left antibodies to do all the work, and somehow our T cell defense mechanisms have atrophied? If SARS-CoV-2 has some antibody defeating mechanisms built in, would that make it more virulent? Because our T cells just aren't what they used to be. I'm sure T cells aren't like muscles, and hope you can add some color to how these things work. Did I understand correctly that sometimes they add things to viruses to bolster T cell responses? I think the idea was loosely inspired by something I picked up from the book 1491, which said Native American populations' immune systems were good at defending parasites, but bad at viruses because of what they were exposed to. And that was partially why they were so decimated by smallpox. I guess if any of this were true, Native and third world populations would fare better against COVID, and I'm not sure there's any evidence of that. So this is all probably poppycock. Thanks, Tommy. P.S. You guys should make Countering the Miasma of Anti-Think on a TWiV t-shirt. I'd buy it.
It's a great idea.
That is a great idea. I'd buy it too. So I think that, Tommy, this is a little bit, I guess, more short term than you're thinking of it as. It's not that someone in your population was once infected with a parasite and so everyone got good at defending against parasites. It's about whether you personally have previously been infected with a parasite or you personally have ever been infected with a virus. And so I don't think that we are seeing situations where our T cell mechanisms have atrophied. We certainly have changed what types of microbes our immune systems see, and that may have altered our T cell responses a little bit, but I wouldn't call it really atrophying. I think our T cells are probably well able to make responses. We just need to do the work of making sure we measure those responses.
I think it's a really good question, right?
Yeah. Mm-hmm. And yes, you correctly understand that sometimes they add things to viruses to bolster T cell responses. That's where you have like a protein vaccine or an inactivated virus where you're not actually making proteins in the person who's vaccinated, but delivering preformed proteins. And in those cases, you are likely to get primarily the antibody response. And in order to boost the T cell response, they add an adjuvant, which actually, I don't know if you were on the show, Brianne, but I described an adjuvant as something that pisses off the immune system.
That is one of the things that an adjuvant can do.
Yeah, okay.
It could either piss off the immune system or make the antigens stick around longer and not get degraded.
I have someone once described it, and I don't really like this, but I'll say it because it's kind of funny. Someone described adjuvant as hamburger helper.
Okay.
Dixon, you're next.
Okie doke. Sonarisa writes, hello to all the TWiV crew wide and far. I just finished a morning walk here in Vermont. It's a very muggy 77F, 25C, 298K, and 537R. Rankin? Who uses this scale? I wanted to say thanks for Vincent's recent rants guilt trips about those of us not listening to the non-SARS-CoV-2 TWiV episodes. Feeling the heat of guilt in the back of my mind this morning, I settled into episode 633, Singapore Viral, while making breakfast. Thanks for the conversation with Ashley St. John about her research on dengue that connects mast cell activation to tryptase release that induces breakdown of endothelial cell tight junctions. Sparks went flying in my head as I listened. I suffer from mast cell activation syndrome, MACS. So I have been spending a good amount of time learning about it since my diagnosis. And almost everything I came across so far in relation to MCAS is about the histamine release and treatments related to controlling histamine. But learning about this effect of tryptase on tight junctions has a lot of puzzle pieces starting to fall into place in terms of migraines, digestive upset, severe blood pressure drops, etc. And it is opening up new questions to consider as I learn more about my condition and ways to help moderate the effects. I will be sending Ashley's paper to my specialist, and after writing this email, I'll probably go down to a research rabbit hole trying to read more about tryptase. Always sometimes fun to learn somewhere. Thank you and the whole team for what you do and share, and it is about so much more than just viruses. Also, I wanted to say that I have skipped episodes, including ones about SARS-CoV-2, but it's not from a lack of love of all things viral, the chatty banter, both of which I enjoy immensely. It is more just that there are a million things I want to learn about, and some days I'm focused on other things, like learning more about mast cell activation syndrome and Lyme disease, rehabilitating our rescue dog, thinking of new ways to access my students for this coming year of remote/non-remote learning, however it may end up. I teach high school maths and physics. Viruses have always held a special fascination for me, even as a kid. I must go back to your archives to look, but I assume you have some discussions somewhere in there about whether viruses are living or non-living. Of course we do. That was always a question I was repeatedly thinking about. I grew up in the high desert West. Summer was always wildfire season. My brain would always connect the ideas to how viruses replicate and have methods to propagate themselves from host to host, and how big fires build their own thunderheads that travel off and strike lightning somewhere further along, starting a new wildfire, replicating with the help of a host in a way like a virus. After completing my undergraduate in physics, I actually looked at virology PhD programs. Although I did not choose that path, the curiosity is still in me. And I would say thanks to SARS-CoV-2, I stumbled on your podcast and have been thoroughly enjoying every bit of it, and it's been rekindling my fascination with viruses. Also, a question for you. I teach math at a ski academy. All my students are dedicated athletes with dreams and goals to reach the most elite level of their sport. In one of Daniel and Chuck's recent updates, they mentioned about the long-term impact on lung function in the context of athletes that might never be able to reach or return to their full potential. I am curious if you guys can discuss this a little more to point me in the right direction for other resources about how to potentially view the impacts of long-term complications of COVID-19. And importantly, how that view changes in terms of risk when you're considering normal people versus athletes operating at the limits of their physical potential. Just thinking of all my students. Thanks again, and stay chatty and grumpy and funny. Sonrisa.
Yeah, I'm afraid it's too early to know any of this.
Yeah, that's
right?
what I was going to say.
Sorry to say this right.
I miss it. Daniel says, because I ask him that, and he says, we just don't know. Whether the long-term consequences are going to be, because we're only 6 months in.
Sure.
But I would say don't get infected. You know, many of the athletes that have gotten infected are out socializing. So you shouldn't do that.
Yes, that's true. Right. That is true.
I know that it's in sort of quote unquote normal people, we're seeing effects where people can actually feel the difference in their breathing or get out of breath doing daily activity, I can imagine that someone who is sort of at their peak, working at the edge of physical performance, would be seeing a change that would be a big deal to them.
Yep.
That's true. There are a few anecdotes. We haven't talked to Ian Lipkin as to how he's feeling lately, but Cuomo's brother and Tom Hanks have made comments about how they felt during and after the episodes that they had. And Tom Hanks, I think, had a great comment and said, "While I was infected, my bones felt as though they were made out of soda crackers." That's an interesting way of describing a symptom. The doctor is, "Well, how do you feel today?" "I feel sort of like a saltine."
So,
but I understand how he.
Would that be different from like a Ritz?
Right. Maybe that's if you're feeling better or if you're being charged more.
Rich, you're next.
Marissa writes, "Dear Rack and Yellow and Twivers, I've been listening to TWiV for the past few months and get all my COVID news from you. I really enjoyed TWiV 609 with Susan Weiss, and as I am an ecologist, your episodes with Peter Daszak. I've also started listening to TWiP and the non-COVID-19 related episodes. I'm writing to you because I am trying to have a COVID-conscious wedding. I've decided on a venue that's all outdoors, way up the Sierra Nevadas. The venue is isolated and there's no chance of strangers to happen on it. Everyone at the site will be people from my fiance and I have invited or hired. I'd like your opinion on whether this is a dumb idea and if you have any suggestions to make it safer. Here are the precautions we have in place. I'm going to go through these because this is incredible. The venue has space for 200, but we're capping the invite list at 30 people. Majority of those attending will be camping. Masks will be worn at all times unless eating or drinking. We'll be providing a mask. No buffet, no serving staff, no dancing. Individual bathroom is restricted to an assigned bathroom. And bathroom use is restricted to an assigned bathroom. Tables and reception area are restricted to one family group per table and 12 feet apart to allow for no mask while eating. Hand washing station positioned throughout the venue. Sanitizing stations also throughout the venue. People spaced 6 feet apart in the ceremony area with mandatory masks. Recommended COVID test within 72 hours of arrival. Stay home if you feel sick. Stay home if you've ever tested positive. Stay home if you ever come into contact with somebody who has tested positive. Stay home if you aren't willing to adhere to our rules. Do you think these are sufficient? Are there any other rules you would recommend? Do you think we should scrap the whole idea? And she's put together a video about the precautions that we could look at with a link to it. It's 10 minutes long. Thanks for all your hard work. I recommend TWiP to everyone. I'm a biological consultant in California, and listening to you makes me feel like I'm chatting with my colleague. I appreciate your respect for one another, except Dixon, of course, and your dedication to high-quality science. Stay safe, Marissa. Okay, here's my answer to this. Forget it, okay? If it's important for you to be officially married, go find a virtual justice of the peace or a mass justice of the peace and do that and put off the party until this is over, because this is a big pain in the ass. You can wait. My wife and I calculated, I figured it out. We waited essentially 23 years for our honeymoon. I think, a wedding is time to be dancing and drinking and kissing people and hugging and, right, eating and just really having a good time. And this is just too much of a pain in the ass. Forget it. It's
also,
okay.
It's California. It's pretty high risk.
Yeah.
If one person's infected, I agree. I think weddings are off right now because the spirit of the wedding is not all this stuff that you're trying to do.
Yeah. Right.
So get married, get it taken care of, but then have a big party in a year where you can really celebrate.
You got it.
Yeah,
that's
you
true.
might be able to find some way to tell your guest list exactly the time and place of your civil ceremony so everybody could have at least a moment of not even silence,
Well, they could bang on a pot just like we do for
a pot.
I have attended a Zoom wedding.
Oh, is that
really?
right?
Yes, during the pandemic.
All right.
So
cool.
All of the guests were invited over Zoom.
I love it.
We all
Yeah,
have
why
champagne
not?
at our own house and toasted.
Right. Why not? And then have the real party later on.
Exactly.
You know?
Hillary writes, listener since March, like a whole lot of your non-scientist audience with a lot to enjoy and not much to contribute till this hit me. Your 4-year-old listener has nothing to worry about the transmission of coronavirus via the human fart. After all, not even the most freedom-loving politician opposes the idea of masking that orifice.
Oh.
Hillary. It's true, right?
It is.
The fart arc. Oh, by the way, there was a previous letter that asked about whether viruses were alive or whether,
yes, that's right.
whether we've ever discussed it.
The one
And
I've read.
boy, I can't remember the episodes. It was soon after I got on, so it's very early in the game. But we had our virus is alive arc where we would debate this almost on every show.
Correct.
And we even sent out a quiz, not a quiz, a survey to our listeners.
That's right.
to see what they felt. I decided viruses were undead.
They're undead. Okay.
I adhere to the theory that if it doesn't generate energy in its own metabolism, it's not alive.
Brianne, you're next.
All right. Stephen writes, Dear TWiV team, Alan and possibly other hosts have on a few occasions blamed CDC for being the only one initially to develop a test. While I won't say that the CDC hasn't had problems, there were definitely issues with their initial assays. There are two problems with this. First, this was not the CDC's decision. It was FDA's. And it was made on seemingly reasonable before the pandemic grounds that in the case of an emergency, laboratory developed tests, LDTs, from high complexity CLIA labs would require an emergency use authorization, EUA, like all other diagnostic tests. Normally, laboratory developed tests, which are used only in-house and not distributed to other labs, do not require FDA authorization. But because of concerns over their accuracy and the importance they have in an emergency, they do need an emergency use authorization in an emergency situation. And he gives a link. I'm told the FDA tried to impose restrictions on laboratory design tests in all situations in the Obama administration, and you can see some of their concerns here. And he gives another link about this. The FDA basically got around this by issuing an EUA, which is the emergency use authorization for all lab-defined tests from a high complexity CLIA lab at the end of March. And he gives another link. The second issue is that the CDC was not the only diagnostic test developer that could get an EUA. They were far and away the first who could get an approval, possibly because they have a leg up since they're a sister organization to the FDA, and since commercially developed tests needed to wait until it became clear that there would be a market.
Okay. I don't know. It seems to me that CDC was the one who said you have to use our tests, though, right? Until you develop your own, and that's when many states started developing their own.
Well, no. So what he's saying here is that labs were not allowed to develop their own because of this FDA decision.
I see. So it was not the CDC's fault. It was the FDA. Got it.
Well, this is one of the many, many, many things that I hope people. This is part of pandemic preparedness. Okay, all the stuff about having tests, having PPE, communication, all of this other stuff is, I hope, things that are seriously considered. I was going to say when this is over, even now, okay, so that the next time around, and there will be a next time, we don't run into these problems. I hope people are really paying attention. We learn from this and put together a good program for the next time we have to deal with this.
Very true.
Dixon, is perfect timing for you.
It is.
I like this one. Yeah.
This is
Alex.
Alex writes, hello, TWiV. I'm an entomologist working as an agricultural biologist / weights and measures inspector. To be pedantic, capitalized, on TWiV 637 and others, while answering email, you all had suggested that the United States should adopt the metric system because of its various inherent qualities. I wanted to chime in and mention that the U.S. is, in fact, a metric SI unit adopting country. The measurement standards for all capitalized measurements made in the U.S. are housed at the National Institute of Standards and Technology, NIST, and are all based on metric measurements that are traced to an international standard. All measurements can be traced back to the national standards. The United States simply adopts imperial units locally for each state. Through this adoption process, measurement values undergo an additional conversion to imperial units for day-to-day use, but are still based on the metric national standards at NIST. I love listening to TWiV, but love TWiP even more. I'm sorry, Vincent, I had to read that. Keep up the great work, Alex.
Notice what he does at the bottom there, Dixon.
I see that.
Insect macro photography. Check out the photos. Really nice.
You know, I actually bypassed that because that's when I stopped reading the notes because,
ooh, yeah.
Very nice picture.
All of this.
Yep. It's really cool. Now, I don't understand. So we are a metric country, but we don't use...
We're not a metric country because
so each state decides. So New York could be metric if it wanted to.
You know who helps on this a lot is Alton Brown. He's a chef on television, and he uses metrics all the time. And then there's this wonderful show called The Great British Baking Show or something like that.
Yes, that's a wonderful show.
That's even better because they use laboratory equipment to measure the weights of sugar and flour and stuff like this. It's fabulous. It's just fabulous. So it's a matter of getting used to it, I think, more than whether you like it or not.
So that's actually very interesting. Officially, we really are metric, but all the localities have maintained a non-metric standard.
Yeah,
weird. Yeah. You know what drives me crazy is that it's not even whatever non-metric is, because none of the scales weigh anything in pounds and ounces. They do it in decimal pounds. Something 0.2 pounds. What the hell is that?
That's right.
Okay.
Yeah, good point.
And the same with miles. It's not.
You're
miles.
right.
You no longer see miles in feet or miles or even fractions of miles. It's something point something mile.
Yeah.
What's that?
That's right. Great point. Rich, next one, please.
Corey writes, hello, TWiV folks. It's a warm, dry, and windy 29C here in Champaign, Illinois, home of the University of Illinois at Champaign-Urbana. I am just a computer support person that has been married to a nursing educator for a long time, so much of the science goes over my head, but I recognize many of the terms. I've been listening to TWiV since March, and I'm glad to have some science-based common sense and reasoning on the pandemic and other things viral. I particularly have enjoyed the episodes recorded back in 2019 in Singapore and Georgia that seem to each presage the pandemic in their own way. By the way, if anybody, I would encourage people to go back and listen to that original Anthony Fauci interview that we did 7 years ago. Okay. Because you get a whole hour and you get to hear Tony talk about, where he came from and all that. It's a fascinating interview.
Yeah.
And at the end of that, we asked him, what keeps you up at night? And he said, pandemic. Talking about presaging pandemics. Our campus of 50,000 plus students is currently planning on reopening on schedule in August. And as part of that process, we will be mass testing faculty, staff, and students using a saliva-based test.
That's smart.
The public details of the plan are in the health and safety section of FAQ at a link that he gives. I believe the details of the saliva-based test are in the following paper. Gives a link to that. What are your thoughts on this test? The sensitivity and specificity were calculated with a small number of samples, and the samples were handled in weird ways. So do we actually even know anything real about the standard deviation. They said using duplicates of test samples, false negatives decreased to 0%. Duplicate equals what? Two run tests? More? Do they intend to perform repeated testing of samples as part of the process, or just for this research? First run has 11% false negatives. So based on prevalence, they'd have to duplicate test almost all samples to get the benefit of increased accuracy. Right? Thanks for all you do, Corey. I have not looked at this. Have you guys? This test?
Yeah, so this is saliva-based RT-PCR, right?
This is the Rutgers test, right?
Well, that's what they developed at Rutgers. Is this the same group? Yep. Let me look here.
It's at Robert Wood Johnson Medical School, I thought.
Oh, yeah? Let me see. I'm just getting this PDF at the moment. This is out of University of Illinois. It's from that university. They did their own
test. I see.
It's their own test. So it's a saliva-based method that bypasses the need for RNA isolation, which is great. So basically, they put saliva right into the PCR machine and run it. So we know that saliva works, and it's good. And this is, this is a PCR test, which, as Michael Minna said, is too accurate. We don't need that. And so you're not able to do as many as you can. And I think that's something now. My thinking has totally changed. And this, not sure when this email came in, probably before Michael's session with us. But if you test frequently, it doesn't have to be that accurate. So your questions about the accuracy here, I don't think are relevant any longer, because, let's say you're early in infection, you're not yet transmissible, you may or may not be positive. Doesn't matter. If you test then the next day or 2 days, then you'll be positive, and then you'll be quarantined, right? So this is not as frequent testing as Michael said. It's better than nothing, right?
I'm looking at the Illinois FAQ document, and they don't really indicate how frequently people will be tested.
Yeah.
They will receive a text message when it is their turn. But they don't say how frequently that will be. And to me, after listening to Michael, the frequency is really the most important part.
Totally. Yeah. I think.
But do you have to be, if you're positive on the first time around, do you have to go and get a second test to make sure you were positive?
I would not. I would just quarantine you. And, it's a possibility that you're false positive, but I don't think you should be retesting under those conditions. I think you should be tested daily if you can, but obviously we can't do that yet. But anyway, so now I have suspicion of any plan that either does not even include testing, and there are some that don't include testing, which is crazy, or if it's not frequent enough. Now, your question about the duplicates. So I don't think in real life they're going to run another test. So you could take the same sample and run it again if you had it, but often you don't have it, or you can go back and get the person. I think in this case, they probably split the samples and reran them. And, from what I learned from Michael, if the RNA is too low, it may be negative one day and positive another day, right? So if you repeat it, that's just validating that. So they're not going to be doing that in real life. They're going to give it a one-shot deal. But again, my problem is how often they're going to do it. If they're not.
What if you don't get sick over the next 14 days after you turn up positive?
Well, that's the risk you take, because you could still transmit, right? So that's why.
That's true. That is true.
It's not just all about you being sick or not. It's about transmitting to other people and restricting that. All right, let me just read this last one because it's relevant to our discussion today. My name is Dave. I'm a physician assistant student in rural Tennessee. The current pandemic has turned me into a listener. Silver lining, right? Because I wanted to know about this particular virus and viruses in general as a consequence of listening. With the talk of a possible mRNA-based vaccine in the works, this is quite old, you can tell, it had me wondering, does this type of vaccine require refrigeration? to remain stable and biologically useful. I'm curious, if it doesn't require refrigeration, how, given that mRNA is relatively quick to degrade? Through additives alone, or could this be accomplished by other means? All right. Do you know anything about this, Rich? Refrigeration?
I looked into it. I can't say I know anything about it, but I looked into it. And I'm just checking my email and text here to see if anything new has come in. No, I looked into this. I tried to find out about it. And in fact, I went so far as to have a text exchange with Jason this morning about it. And Jason didn't know either. And he said that he would contact Barney Graham and that Barney ought to know. And so I would assume that at some point or along the line, we will know. Here are my thoughts based on what I've read. First of all, what we've talked about, fearful of, is the notion that you would have to keep this thing at minus 70. That is deep, deep freeze. And that you just can't. I don't think you can maintain a cold chain doing that. Even if you have to have a cold chain, you can't maintain a cold chain of that. And I can't, damn well, if you look at the literature, it's clear people are thinking about this. Okay. So this has got to be part of their shtick. Okay. And I assume that at some level this problem has been solved. And by at some level, I mean either that they have something that is stable enough so that it can be handled with a normal cold chain, which is basically refrigerator temperature, or maybe even frozen in transit over long periods of time, but can survive what the sorts of distribution that are currently done with vaccines that need to be kept cold, or that they've figured out a way to do it at room temperature. I don't know what the answer is, and we will find out. And even the people who I know who should know don't know yet. Okay, so we'll find out. The other thing I found out that was interesting, and I don't know if that applies to this, is that one of the things that have been looked at is lyophilization.
Right.
Okay, because you can lyophilize RNA and keep it indefinitely, and then rehydrate it. That's freeze drying for the
that's right
for the uninitiated, and then rehydrate it, and it's okay. Now, I don't know if that applies to this because we're talking about nanoparticles.
So, everything you're saying here is sort of exactly something I was thinking about while reading the paper, because I do a lot of experiments where I transfect DNA into cells, and so I have to make DNA coated by a lipid. And I know all of the things about how I have to treat that lipid and DNA complex. And I realized that they clearly had some special lipids that are much fancier than what I have to be stable to work in this vaccine. But I also know that sometimes I buy them that are freeze-dried with the lipid around the nucleic acid. And so I got really curious about what their lipids were, maybe because I read this paper right after doing a transfection in the lab, but I suddenly wanted to know a lot about those lipids. And I think they would impact the storage quite a bit.
So at any rate, we will find out the answer to this and come back to you on that. But I would say I have to believe that they have it at least figured out well enough so that they can use the standard practices that are used for vaccines that need a cold chain.
I would think so. Otherwise, they're not making all those 500
otherwise
million
you
doses.
Just can't do it. Yeah, right.
Correct.
Okay, that'll do it for TWiV 642. You can find it at microbe.tv/TWiV if you want to look at the letters and the links we give. Otherwise, you can play it on your iPhone or Android or tablet, whatever you got. And please subscribe. We'd love to have you stick around. If you like what we do, consider supporting us. You can go to microbe.tv/contribute. We have several ways for facilitating your departure from your money. Make it very easy for you to do that. And if you have questions or comments, send them to twiv@microbe.tv. We will get to all the questions. If it takes another 10 years, we'll get to them. It will take 10 years. Brianne Barker's over at Drew University, which we learned the history of in the pre-show. Thank you, Brianne.
You're welcome.
Bioprof,
it was great to be here.
Bioprof Barker on the Twitter. Rich Condit is an emeritus professor at the University of Florida in Gainesville, currently residing in Austin, Texas. Thank you, Rich.
Sure enough, it's a privilege.
Dixon Despommier can be found at trichinella.org and thelivingriver.com. Thank you, Dixon.
You're welcome.
And behind him are his hobbies. Isn't that a lovely shot of Dixon? Look.
Yeah.
It's a nice
behind me.
It's a nice background. You have your
paint.
You have your
this
painting
is my fly
stuff.
tying unit.
You got fly tying, but you have also your color, your brushes and
You're
paint.
painting.
Yeah, that's true.
Are you a watercolorist?
I am. Do you want to see one?
I have one on my wall here,
You do? No,
Yeah,
I want to show you the one I really like.
Okay. Oh boy, now we have to wait. He's got a nice chair. He has my chair, actually. Look at that.
Dixon's got his act together.
Why do you say that?
He does lots of stuff. And he keeps himself, busy. Look at that.
Nice.
Very
A bowl of
Very
lemons. Nice. And it's got his signature. Very nice, Dixon. Beautiful.
He needs a gaming chair.
He does need a gaming chair.
I have
a chair. He's got the same.
I've got a terrific chair. It's just that
same as mine, Dixon, right?
Yeah, I got the same chair too.
You have the same chair as mine, right?
Yeah,
I do.
Yeah, there you go.
Yes, I do.
Thank you, Dixon.
You're welcome. This was fun.
I'm Vincent Racaniello. You can find me at virology.blog. By the way, Dixon, that was a beautiful watercolor, right? It was lemons in a bowl,
Glad
right?
you liked it.
I love it. I have one of his on my wall here. It's beautiful.
Done it in a while. Maybe I'll go back.
Show it to you another time. I said I'm Vincent Racaniello at virology.blog. I'd like to thank the American Society for Virology and the American Society for Microbiology for their support of TWiV and Ronald Jenkins for the music. This episode of TWiV was recorded, edited, and posted by me, Vincent Racaniello. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral.
I will just tell you quickly, Alan, I now have a gaming chair. I have had it for a few days, and I am a huge fan. So
nice,
thank you.
Isn't it?
Yes, thank you for the recommendation.
It's got the same shape as Alan's. Look at that.
Yeah, in fact, I saw you got the GT Racer.
I did.
Yeah.